A very good evening to everyone. I, Dr. Poonam Joshi, on behalf of Head Neck Surgical Oncology Department, welcome you all to our TMC Postgraduate Teaching Webinar 2023. The theme of this conference is Back to Basics of Head Neck Surgery. Now, I would like to invite Dr. Gauri Pantavaidya, Madam. Madam is Professor in Department of Head Neck Surgical Oncology, Tata Memorial Hospital, Mumbai, to give the opening address. Over to you, Madam.
Hello, good evening. Can you hear me, Poonam?
Yes, Madam, we can hear you.
Yeah, good evening, Poonam, and good evening to everyone. A very warm welcome to all students, faculty, and delegates to this third TMC postgraduate course. This course has been planned. The content of this course has been particularly planned, keeping in mind students who are in training. And it really is a very, very comprehensive program in the next 2 days. It covers everything from case presentations, which are going to be done by our students, moderated by faculty from all over the country. There also is a good lot of panel discussions, and the one good thing that I see in this course is that we are also discussing some nuances of surgical technique. I'm not going to take any more of everyone's time. Best wishes to everyone. I'm going to just take a little bit of time to thank Dr. Poonam Joshi, who is our professor at ACTREC, who has put together the content and everything and organized this course. So thank you, Poonam. I wish all the students and everyone in the course best wishes, and we can go ahead with the course. Thank you, Poonam.
Thank you so much, ma'am. So with this, we start the program, and I hand it over to Dr. Mansi, who is our fellow, HBNI fellow in Department of Head Neck Surgery, Tata Memorial Center. Over to you, Mansi.
Thank you, ma'am. Good evening, all. Without a further ado, let us start with the first session of day 1, which is on case presentation and discussion, carcinoma upper alveolus and upper GPS. The expert panel for this session is Dr. Deepak Sarin, Director, Department of Head and Neck Surgical Oncology, Medanta, the Medicity, Gurugram. Dr. Pooja Pal, Consultant Head and Neck Oncosurgeon, Gurugram Institute of Medical Science, Amritsar. And Dr. Ravi Shankar, he is Consultant Head and Neck Oncosurgeon, HCG Group of Hospitals, Mumbai. I also request Dr. Gauri ma'am to kindly be a part of this panel. The moderator is Dr. Pallavi Kaul. She is Assistant Professor, Department of Surgical Oncology, Shri Mahant Interesh Hospital, Dehradun. The presenter for this session is Dr. Reshma R. Balchandran. She is Surgical Oncology Resident at Tata Memorial Hospital. I would request Dr. Reshma to kindly proceed with the presentation.
Good evening, everyone. Starting with the case presentation. My patient is a 42-year-old gentleman who is a market sales executive coming from Panvel, Mumbai. He presents with a complaint of an ulcer in the right upper jaw over the last 1 month and fullness over the right cheek over the last 2 weeks. History of presenting illness. Apparently normal patient till 4 weeks ago, he started noticing an ulcer over the posterior aspect of the right upper jaw, which was initially painless to begin with and progressively increasing in size over the initial 2 weeks. So with these complaints, he consulted a nearby doctor and took some medication and also applied an oral ointment, but it was not subsiding. And during the same time, the doctor noticed another swelling in the right neck, which was subjected to needle examination by the doctor, and he was referred to TMC for further evaluation. Meanwhile, the ulcer has progressed further in size, and it was associated with an intermittent dull aching pain, which was non-radiating. And over the last 2 weeks, he started noticing an increasing fullness over the right cheek. There is no history of any pain in the ear, no history of any bleeding from the ulcer, no history of any difficulty in mouth opening as complained by the patient, no history of any loosening of the tooth recently. No history of any excess salivation or intolerance to spicy food, no history of any sharp tooth, no history of any similar lesion elsewhere in the mouth or any hoarseness of voice or any difficulty in swallowing, no history of any cough, hemoptysis or breathlessness, no backache or bony pain, no history of any headache or seizures, no abdominal pain, no history of loss of weight or loss of appetite. Past history, he does not have any comorbidities, nor he has undergone any previous surgeries, no drug allergies. Coming to the personal history, he consumes non-vegetarian diet, sleep and appetite is normal, and normal bowel and bladder habits. My patient is a chronic tobacco user in the form of a chewable tobacco. That was supari, which was mixed with tobacco. He used to use some packets over the last 20 years. So he used to take 1 to 2 packets per day initially, and later on it increased to about 10 to 15 packets per day till now, which has stopped over the last 3 weeks. No history of any smoking. And he is an occasional alcoholic, which is unquantified over the last 15 years. And he stopped consuming alcohol for the last 3 weeks. Family history, his father and mother died of old age illness, no siblings, no significant familial illness in the familial illness. Summarizing the history, my patient is a 42-year-old gentleman with no comorbidities or any significant family history, who is a chronic tobacco chewer over the last 20 years and occasional alcoholic, presenting with a 4-week history of a gradually progressive ulcer over the right posterior upper jaw and associated right cheek fullness and right neck swelling over the last 2 weeks.
Should we ask questions now or should we wait for the end? How do you think? Pertaining to the, can I go ahead with any questions right now?
Sorry, ma'am, 1 second. I'm not able to hear you.
Can you hear me now?
Pooja, I think your volume is very low. I don't know. Can you hear me well?
I can hear you completely well. Can you hear me?
Yeah, I can, but your volume is really faint. So it's a bit of a struggle to hear you.
Okay, I am actually out of station, so there's a bit of an audio problem.
Okay, we'll just focus harder, I think. So Reshma, I had a couple of questions for you.
Yes, sir.
When you saw this patient's history, given that we are all thinking this is likely going to be cancer in the mouth, what is your impression based on this patient's history? Are we dealing with a good average cancer or a worse than average or a better than average cancer?
So I think we are dealing with a probable bad cancer because my patient is a young gentleman who is a chronic tobacco user, started using supari mixed with tobacco initially around 1 to 2 packets, which increased to about 10 to 15 packets per day. So which means a significant history of a tobacco usage and occasional alcoholic. So there is a combination of tobacco along with alcoholic. And it is a very short history. So within 4 weeks, his complaint started 4 weeks back. It started as a small ulcer, and as per the history, it gradually progressed over the last 4 weeks to the current size. So,
right. I think 3 things in his history that worried me. One is, as you said, short history. The second is he has pain. That's generally aligned with cancer. And third, he developed a cheek bulge within 2 weeks. Again, that indicates a large volume, deeply infiltrative disease.
yes, sir.
So all these 3 things tell you that this is likely a biologically poorer version of the cancer. Did you mention about trismus?
Yes, sir. So as complained by the patient, he does not complain of any difficulty in mouth opening. But on examination, we were able to, that I'll come to it during the examination.
And you took a specific history about hoarseness and swallowing difficulty. Why did you do that?
So usually for head and neck malignancies, there is a tendency to develop a second primary malignancy. But in case of oral cavity, the second primary site will most commonly be an oral cavity malignancy only. But for the completion, and because he is a chronic tobacco user, I would just wanted to rule out any history-wise, any association with a second primary malignancy, as in any other lesions in the any larynx, any difficulty in the speech, hoarseness of voice, or yeah.
Excellent. I just have one comment. I'm not sure what an occasional alcoholic is. Occasional consumption of alcohol, I understand. Occasional alcoholic means that he drinks like crazy for a few weeks, then doesn't drink for a few weeks, then drinks like crazy for a few weeks. So maybe occasional consumption of alcohol is what you meant,
Yes,
not
sir.
occasional
Consumption
alcoholic.
of alcohol.
Yeah. So that's it. Any Baki Dr. Pooja, Dr. Ravi, over to you. You have any questions?
I'm trying with my with the phone, but the host is going on muting me. So can I? Is the audio better with this?
Yes,
It's
Doctor.
better.
Yes, ma'am.
Much
Okay,
better.
the host is going on muting me. I don't think they know it's me. So can you please request them not to mute me? Okay, I just wanted to ask, like Dr. Deepak only mentioned regarding the trismus. Now you said that you want to rule out anything. If the patient tells you that he's having trismus since the past 7 years, how do you interpret it? And this lesion is there since the past 4 weeks. So will it make any difference to your interpretation?
So my patient is not complaining of any difficulty in opening mouth over the last
Agreed.
4 weeks.
Supposing he said he had a history of trismus in the past 7 years.
Mm.
So what would you attribute it to?
So then we should think in terms of other cause of trismus, as in because he is a chronic tobacco user, I will have to rule out any symptoms of like any submucous fibrosis or anything developing in the oral cavity.
Okay.
That is one thing.
And supposing he has a history of trismus in just the past 10 days, then what would be the most likely cause?
So then I should be thinking of a very aggressive malignancy, which might be infiltrating deeply to be very specific, infiltrating onto the muscles of mastication, or maybe affecting the temporomandibular joint, or even causing some bony infiltration. And due to the pain, it could be a reflex response to the pain as well. The trismus can be due to a reflex response to pain as well, if there is an underlying bony infiltration also. So I should be thinking in terms of all these, like a deeply infiltrating or an aggressive tumor, which would be advancing deeply.
Correct. And how would you differentiate whether it is the trismus is because of the pain or whether it is because of infiltration? Anything you can do to differentiate between the two?
From the history, ma'am, you're asking?
No, not history. If you want to examine the patient or anything, how will you differentiate whether the trismus is because the patient is having pain or because of infiltration of muscles or mastication? Anything that you can, which will help to differentiate it, because it makes a huge difference in the treatment, right?
Okay, so maybe on examination during the palpation, I may be able to palpate for any tenderness, especially over the bone.
Which bone are you planning to palpate?
So this being a tumor in the right posterior jaw, I would palpate for the maxillary alveolus.
I think if the ulcer is there over the alveolus, the patient will have pain irrespective of there being any infiltration or not. Anything else that you can do which will help to differentiate it? If you do an examination under anesthesia, which we do routinely to evaluate, for example, any large tongue lesions, if
right,
it is because of
yes.
spasm, then the trismus does get relief because
Yes,
the patient's pain. So that makes a huge difference.
Yes, agreed. Yes.
And another question, at the end of the history, what is your provisional diagnosis, depending, looking at all the history that you have given?
So based on this very short history and the history of tobacco chewing and alcoholic, and a very short history, I would think of a malignancy as my first provisional diagnosis.
Okay,
so
malignancy of what would be the subside that you would probably pinpoint it to?
So it started as an ulcer in the right buccal mucosa, according to my patient from the history. So subside will be the upper gingival-buccal sulcus.
Okay, because you have mentioned an ulcer on the upper alveolus, upper jaw in your history. That's why I was just asking.
Yes, that was how he described his common terminology.
Okay, what are the features in favor of upper GBS on history? On history, okay, what is there? You have a couple of things which are in favor of pinpointing the lesion to an upper GBS just on the basis of your history.
Okay, so for the last 2 weeks, he is having
pains.
So for the last 2 weeks, my patient is having experiencing a fullness over the right cheek. So that is suggestive of something growing over the right upper gingival-buccal sulcus.
Correct. And one more thing on history, a very significant finding which you have mentioned in history.
So
for which you tend to think more in terms of upper GBS rather than upper alveolus.
So it was initially painless to begin with.
Something else? You mentioned a neck swelling, right?
Neck swelling, yes.
He went and got an FMAC done. Okay, so we all know that the chances of lymph node mets are much higher in an upper GBS rather than if the patient had an upper alveolus. So that is another very significant history which you have mentioned. Okay, so we're already thinking in terms of upper GBS and not in terms of hard palate or upper alveolus.
One more thing, Dr. Reshma, that I would like to point out. You told that the patient was having only the history of tobacco chewing. Usually in India, the practice of tobacco chewing, the patients keep it in the lower GB sulcus or the lower gingivolingual sulcus. This patient is having a lesion in the upper GB sulcus. There's very high probability that this patient might be using gutka as well. Because these gutka is the main causating factor causing a lesion in usually in the upper GP sulcus. So the important point is if the patient is a gutka chewer, we have to be wary and look for be cautious about any associated oral submucous fibrosis or because these patients, they end up with a condemned oral mucosa. So there are very high chances of being some other lesion which can be missed if we do not examine these patients properly.
Yes, right. Okay, shall we move on?
Yes, go ahead.
Coming to the general examination, my patient was conscious and cooperative, oriented in time, place, and person, with an ECOG performance score of 0. He was moderately built and nourished, with a BMI 29.5, no pallor, icterus, cyanosis, clubbing, no generalized lymphadenopathy, no pedal edema. Vitals were normal, and he was afebrile during examination. Coming to the local examination, on inspection, there is a visible fullness over the right cheek, just below the right zygoma, compared to the left side. His mouth opening was there was mild restriction in the mouth opening, with an interincisal distance of 3.5 centimeter. There was halitosis. He was completely dentarless, and there was tobacco staining over the entire teeth. There was a single ulceroproliferative growth, approximately 5 into 2 centimeter, in the right upper gingivobuccal sulcus, reaching the buccal mucosa with the following extent. Anteriorly, it was reaching till the right canine first premolar junction at the dentate level, with the surrounding edema and inflammation reaching up to the oral commissure. Posteriorly, the lesion was reaching up to the third molar and just reaching the RMT, retromolar trigone. Superiorly, it was involving the upper gingivobuccal sulcus. The palatal surface of the upper alveolus was free. Inferiorly, there was a visible edema reaching up to 1 centimeter from the lower gingivobuccal sulcus. This was a lesion. The edges were rolled out with the surrounding erythema, and the adjacent area, buccal mucosa, shows erythroplakia antero-inferiorly. No other lesions visible in the entire oral cavity or the contralateral vestibule. No visible neck fullness was found on examination, on inspection. Coming to the palpation, there was no local rise in temperature. Tenderness was present on deep palpation. Mouth opening interincisal distance was 3.5 centimeter. Inspectory findings were confirmed with regard to the size and extent of the lesion. Margins were indurated. On bidigital palpation, the tumor was very close to the skin. The skin was not freely pinchable. There was no loose tooth and no altered sensation in the infraorbital region. Examination of the neck revealed a single non-tender hard node 1.5 into 1.5 centimeter in the right level 1B, which was mobile. No other lymph nodes were palpable clinically. Hopkins examination was within normal limits. Systemic examination, no significant finding. Spine and sternum were normal. With this, I come to a provisional diagnosis of a carcinoma right upper gingivobuccal complex. Clinical staging CT4B N1M0. HSCC 8th edition staging, stage 4B.
Why are you calling it 4B? What are the features in favor of 4B?
So that was made after also comparing the radiological imaging. So yeah, so history-wise, my patient was not complaining of a difficulty in the opening the mouth, but on examination, it was found that he was having an interincisal distance only of 3.5 centimeters. So there was a mild restriction in the mouth opening. So clinically, the tumor might be infiltrating deeply to involve the masseter or the muscles of mastication, leading on to difficulty in opening mouth. So in that way, it would be breaching the masticator space. So which would make the staging T4B as per the
features of submucous fibrosis in this patient.
So it was not found. So I palpated the entire oral mucosa. I could not feel any vertical bands or anything. or there was no pale mucosa like appreciable over the soft palate or the pterygomandibular raphe area. So I could not find clinically any features of oral submucous fibrosis for this patient clinically.
In which stage of submucous fibrosis will you find palpable bands?
So it will be in stage 3 as per Khanna and Andrade grading. So that grading will be like grade 1 will be when the interincisal distance is more than 3.5 centimeter. Grade 2 will be from 2.5 to 3.5 centimeter mouth opening. Grade 3 will be 1.5 to 2.5 centimeter. So in that there will be palpable bands over the soft palate, over the palatal tonsillar pillars, and over the pterygomandibular region.
Okay.
Yeah.
Dr. Deepak, any questions? You can go ahead. Can you show us the imaging?
Yes, ma'am.
Yeah, can you hear me, Reshma? Sorry,
Yes,
I think
yes,
I was
sir.
muted, so I couldn't ask. You said the skin is not pinchable on exam. So what are the reasons why you may find the skin not pinchable over a buccal mucosa cancer?
So in case of buccal mucosa cancer, when the tumor is infiltrating on or breaching the area of the buccinator muscle, then the overlying skin might not be pinchable. So which means that that skin should come out, or it would be difficult to get a margin over that area.
So one is direct tumor infiltration.
Yes, direct tumor infiltration.
Sometimes even peritumoral edema can give the impression that the skin is not pinchable or possibly involved. But the two can be very difficult to differentiate clinically whether it's direct infiltration. Secondly, this growth that you described as ulceroproliferative, I would probably describe it as a highly ulceroinfiltrative growth. It really looks like you have a small mucosal component, but a very, very large submucosal infiltrative component. So there's probably a proliferative component, but there's definitely a very, very strong infiltrative component that I would keep in mind.
Yes.
Now, when you're examining a patient with a buccal cancer related to tobacco chewing, other than examining the lesion, what aspects would you pay a lot of attention to which have important bearing on your management or your surgery, other than the lesion itself?
So clinically, we have to look for any other presence of any other similar lesions in the oral cavity or the palpable examinable areas of the oral cavity and the oropharynx.
Okay.
Second thing, we should examine for the feature suggestive of local deeply infiltration of the tumor, as in case of examination for a trismus. Or
no. So Reshma, your question is, other than the tumor, what else do you pay attention to in the oral cavity in a patient with chewed tobacco related cancer?
Okay, one, look for any other pre-malignant or any other malignant lesion elsewhere in the oral cavity.
Right. So I think you also need to pay attention to trismus if it is, whether you think it is tumor related trismus or not.
Yes.
If it's submucous fibrosis related, you may want to think of releasing that in your operation. And the third thing, I think you want to look at impinging teeth. People with submucous fibrosis often have impinging teeth, particularly, for example, if they have the last molar. And you may want to consent or plan of extraction intra-op, given that if you radiate them with impinging teeth, last molars, they can have a really tough time later in life. Okay. So, in these patients who have SMF and trismus and chewed tobacco, you need to pay a little attention to the rest of the oral health to get them ready for their entire treatment course, which is improve their mouth opening, get all impinging teeth out. And of course, as you said, look for any other pre-malignant lesions that need to be managed simultaneously. What's the clinical implication of erythroplakia?
So erythroplakia is otherwise described as a very dangerous oral mucosa, because in majority of the cases, the lesion will anyway be harboring like any kind of any carcinoma in situ or any levels of dysplasia, mild, moderate, or severe, or even a carcinoma in situ within the lesion itself. So the risk of malignant transformation in erythroplakia is very high compared to that of a leukoplakia or any other lesion. So that makes it very significant, because if our primary modality of management would be surgery, then that should definitely come out with the main lesion.
Right. And when you see leukoplakia, how do you assess the risk of malignant transformation in a leukoplakic patch? How do you gauge in your head? How do you decide what to do with this leukoplakic patch in a patient who's just come with leukoplakia? Ignore the cancer for now.
Okay, so someone presenting with a leukoplakia, so the risk of malignant transformation in a leukoplakia can range from like 17% to about 25%, depending on the type of leukoplakia. So we have to examine what type of leukoplakia it is, whether it is a homogeneous or a non-homogeneous, which could be either a speckled leukoplakia or a nodular one or a verrucous leukoplakia, which has a, in that specifically like something like a proliferative verrucous leukoplakia, which has a very high risk of malignant transformation. Second thing, the location of the leukoplakia. There are some subsites where the risk of malignancy would be very high, as in case of like occurrence of a leukoplakia in the floor of mouth or in the lateral border of tongue or in the lower lip, which are very high malignant probable sites. Then the size of leukoplakia. If the size is more than like 200 millimeters square, then again there is high chance of malignancy. Then leukoplakia occurring in a female, somebody who is a non-smoker, who does not have other predisposing factors. So then they have very high risk of malignant transformation. Also, a leukoplakia associated with oral candidiasis also is said to be very high risk. So we have to look for all these features, and based on that, we have to take a call whether to resect it or not, or to keep under close observation.
Excellent. The only thing I may not agree with is the risk of malignant transformation, which you quoted from 17 to 25, which I think to me sounds pretty high. I can't give you figures offhand, but I'm guessing if you have a small flat white buccal patch, it would be fairly low, maybe under 5%.
Range is 1 to 17, and for erythroleukoplakia, it goes up to 40.
Perfect. I would agree with that.
That is
for low risk leukoplakia, I think it's very low, but it can go as high up to 50 with if you have high risk features coming on.
Okay, sir.
Okay.
I have one question, sorry. Supposing in this patient, only looking at this image, supposing the patient had another ulcer, probably at the level of the second molar, the lower second molar, and you did a biopsy and that too has come positive. So would you label it to be a second primary, or how will you go ahead with this?
So the definition of second primary, we would define it by using the Warren-Gates criteria. So both lesions should be distinct, both should be malignant, and the probability of one being the metastasis of other has to be ruled out. So which would be very difficult in case if I'm finding another ulcerative lesion near the lower second molar. So in this case, probably I should call it something like a second field tumor, which is synchronous with that of the index lesion. In this case, if we are finding another ulcerative lesion in the lower GBS, because our patient is having a chronic tobacco exposure. So all these oral malignant lesions arise from a single pre-malignant clone of cells arising from the basal layer of the oral cavity mucosa. And then they divide, and then they develop many genetic alterations, and they develop to form a patch. And the patch can expand, and then it would become a field of genetically altered cells. So in that, two different lesions can develop at the same time. So in that case, we would call it as a second field tumor.
Okay. Can you describe this for the first time, field cancerization? So
the concept of field cancerization was first described by Slaughter in 1953. And later on, so when he gave that concept, even the Watson and Crick had not even developed the DNA structure during that time. So later on, after so many studies, the recent study by Brackus et al., so he has proven that the original statement given by Slaughter was very accurate in terms of the molecular genetic alterations, which is happening in all these tumors. So they have given solid evidence. Now we have solid evidence to state the biology behind the occurrence of the second primary as well as second field tumor. So we categorize them based upon their molecular features, seeing at the genetic level what is exactly happening with these tumors.
Correct. And if you have two patients, one with an upper GBS tumor and one with a lower GBS tumor, which one would you label as a better one? Obviously, they are both not good to have, but which one would be more aggressive or with a worse prognosis, the upper GBS or the lower GBS?
So I think upper GBS tumor should be labeled as the one with a poor prognosis compared to the lower GBS.
Okay, can you give me some reasons for this?
So if the tumor becomes advanced, the possible sites of tumor infiltration, as in case of upper GBS, it can go directly behind to the retromolar trigone and then enter into the masticator space through the pterygomaxillary fissure. It can go to the pterygopalatine fossa, and it can become inoperable very quickly.
Correct.
Compared to that of a lower GBS tumor. So in that case, yes. And also it can even once it gains access to the pterygomaxillary fissure, it can even go up through the pterygopalatine fossa to the high infratemporal fossa and even to the high ITF also. So then I think upper GBS tumor should be considered as more aggressive compared to a lower GBS tumor.
Correct. So there are basically 4 reasons. One is that they usually present late, and they present once they have escaped into the ITF or into the cheek. So automatically worsen the prognosis. Secondly, they, like in your case, the external skin gets involved, it involves the ITF to a large extent. These tumors usually require some reconstruction also. So automatically it becomes more extensive. And third reason is that it is difficult to get margins at this area. As everyone knows, the surgery is always more challenging. And last is if the patient develops a recurrence later, the chances of salvage are very poor. Okay, so as compared to a lower GBS one, considered to be more aggressive.
From where would you like to biopsy this lesion? Would you like to biopsy this lesion first?
So if I have this patient in my OPD, so I would like to do a biopsy because it can be done as an office procedure and the report would anyway take 5 to 7 days. So I would like to biopsy this patient, and I don't think that biopsy, because I'm not going very deeply, it might not affect any imaging modality which I'm going to do later. So I would like to biopsy this patient right away. So I would choose a most representative area, avoiding the area of necrosis, and I would prefer a punch biopsy, so which can easily be done as an office procedure. So in this, I will
the
do
most sensitive area in this, especially in this lesion of yours. What would you consider to be the most representative area?
So in this lesion, either I can take somewhere from here. So these all whitish areas appear necrotic to me. So either I can take from this area where it appears to be a representative area, or I can take from this anterior aspect also.
Correct. How will you decide? One, you said that you will try and avoid anywhere where there's necrosis. Anything else that you can do to find out which is the most likely area to give you a positive diagnosis?
So previously we used to say like should be from the edge of the lesion, so that we get an area of the normal mucosa also. So that way, if it is possible, then it would be better, I think.
No, nowadays we don't take it from the edge, right? We take it from the
representative area. Yes.
So you would definitely palpate this lesion.
Yes.
Because erythroleukoplakia and all that is not going to have a lot of induration. So you'll see the site which is got the highest induration. And would you do a punch biopsy for this patient?
Yes, punch biopsy.
Why not a knife biopsy?
So with a punch biopsy, if I'm able to get an adequate chunk, then I think that should suffice for the initial primary diagnosis.
Okay, I would probably go for a knife biopsy because I agree with Dr. Deepak. It looks more like an infiltrative or a verrucous lesion turned bad. So if you want to get the basement membrane into your
it looks more of an ulcero-infiltrative lesion over an ulcero-proliferative lesion with a lot of induration and peritumoral spread and submucosal spread of the disease. So knife biopsy would be much better for this lesion over
positive
punch biopsy.
Okay.
Karishma, what other workup would you plan specifically for this patient? Forget the general workup from oncologic standpoint.
So first thing, I would like to investigate my patient to confirm my diagnosis. So I would do the biopsy right away. Second thing, I would like to know the anatomical extent of this lesion, and I would like to stage the disease. So for that, I will ask for a contrast enhanced CT scan of the head, neck, and thorax in this case.
Okay.
Apart from the general routine investigations.
Would you consider a PET scan?
So in this patient, at this point, I would not want to do a PET CT scan. No. So because the chance of the possibility of an extra thoracic metastasis without a lung metastasis in case of oral cavity malignancy is less than 4%. So if my CECT thorax does not reveal any evident parenchymal lung metastasis, or clinically on palpation, there were no lower neck node level or multiple neck node levels involved. So I do not, and my patient is not giving any symptoms pertaining to the presence of a distal metastasis. So in him, clinically, I'm not suspecting a distal metastasis at this point. So I would not want a PET CT in my first sitting. So my first investigation of choice would be CECT, head, neck, and thorax.
So, okay. So in our place, we tend to do an HRCT for the thorax because a contrast scan of the thorax does involve a lot of contrast being shot in. I don't know if there is a preference for one over the other, but we would generally do an HRCT to assess the lungs. The second is, so then when would you in an oral cavity cancer case in an upfront setting?
Sorry, sir, when would we?
In a treatment naive oral cavity squamous cell carcinoma, when would you order a PET scan?
So yeah, first thing as we discussed, if we are suspecting a distant metastasis, as in suppose our patient is having a lower neck nodal level involvement, where we are expecting a mediastinal lymph nodes also to be involved or any presence of distant metastasis. So one is that setting. Second thing, if we are dealing with a recurrent tumor. Third thing, if we want to rule out a second primary, if we are strongly suspecting a second primary in this patient, then we would want to do a PET CT.
In this patient, would you expect a second primary to be in the lung or somewhere else?
So usually in case of head and neck oral cavity malignancy, the most common site of second primary would be an oral cavity itself. The most important risk factor for my patient was a chewable tobacco. So which would either amount to oral cavity cancer or would amount to then pancreatic cancer. So unless my patient is not giving any symptoms pertaining to that, I would not suspect that, and then I would not warrant any other imaging.
Which patient would have a second primary in the lung more likely with a primary affair? And then support.
So
No, I'm not sure.
Dr. Reshma, we have two
Yes.
types of tobacco consumption, right?
Yes.
What are
yes,
the
ma'am.
subclassifications of tobacco?
So tobacco, yes. So tobacco as a carcinogen can be in a smoked tobacco as well as smokeless tobacco. So smoked tobacco basically contains the polycyclic aromatic hydrocarbons and the nitrosamines. So which would basically cause malignancies of the larynx or the aerodigestive tract and the lung malignancies. Chewable tobacco mainly contains N-nitrosamino nornicotine or 4-methyl nitrosamino butanol. So that predominantly causes the oral cavity malignancies.
So that primarily answers the question Dr. Pooja is trying to ask you.
Yes, you have the Hotty's axis, right? So if you have an oral cavity lesion, more likely it will be in the aerodigestive
Or
tract.
aerodigestive tract.
The larynx, then it is more likely to be in the lungs. Okay.
Okay.
So Reshma, would you consider an MRI in this patient?
So at this point, after seeing my CECT, if I have any suspicion of, so in my CECT, which I'm going to show, if I'm suspecting any extension to the maxillary sinus or any perineural invasion, which I'm suspecting, then I would want an MRI, but not in the primary setting. My first investigation would be CECT only. If in the CECT I have a suspicion of these features, then only I would like to go ahead with an MRI. Also, if there is any evidence of upper alveolus erosion where I'm suspecting a marrow invasion, then I would want to do an MRI because then I'll have to plan my bony cuts. So I would want to know the extent of the marrow involvement if it is there. So in that case, I may ask for an MRI, but not without seeing my CECT scan.
So you said if you suspect perineural invasion, how would you suspect that? So
in the CECT scan, if my tumor is reaching to the clinically this tumor is reaching the RMT. So if in my CT scan the tumor is entering into the masticator space and beneath the RMT, if it is going. So if I'm suspecting any, so in that case, if it is reaching the area of distribution of the mandibular nerve or the maxillary nerve, then I would suspect a perineural invasion in this case. So then I may ask for an MRI to rule out that, because any subtle changes of subtle perineural invasion changes might not be evident in a CECT scan as evidenced in an MRI.
Dr. Reshma,
Like on scan, I agree it will be in the advanced stages, but what can give you a clue regarding perineural invasion on a CECT?
So one thing is patient might be having some
There is one sign which you can get on a CT scan also if there's significant perineural invasion. I agree it's not an early infiltration in advanced stages.
Okay, yes, CT scan in advanced stages, if it is through the perineural invasion, if it is reaching till the base of skull, then there can be foraminal widening or any erosion of the bony foramina, skull base foramina.
Like
Only at that point,
it
it may be evidenced in a CT scan.
Also for clinical examination, from a clinical examination point of view, the presence of paresthesias in the distribution
Yes.
of nerve will point towards a suspected perineural invasion, and you should better look for that.
Yes.
So Reshma, I don't debate your logic. It's just that in this case, to me, it looks like a very deeply infiltrative lesion. I think there's a high chance you will find masticator space involvement. It will be very unusual for you not to find it. I would have preferred an MR upfront in this case, just to get a better delineation of the infratemporal fossa extensions. But it's fine. I mean, I'm not going to debate if you're going to do a CT and then keep an MR in reserve. Because generally for ITF extension, you'll find an MR will give you better definition and actually is shown to be of better sensitivity for picking up involvement in that area.
What all findings will you significantly look for when you do a CCT? What all you mentioned? One is bone erosion, that I agreed. What else?
So anatomical extent of the lesion. Specifically, I would want to rule out the extent of tumor into those areas which would affect my resectability. So as in extension of tumor into the masticator space, one thing, into the infratemporal fossa and extension into the high infratemporal fossa. Then extension of tumor into the pterygomaxillary fissure or the pterygopalatine fossa, that area. Then as it is, as the inferior extent of this lesion is just 1 centimeter short of the lower GBS, and it is reaching the RMT, I would want to rule out any erosion of the mandible as well.
Okay, so you
also regarding the neck nodal involvement.
Correct. Coming to the masticator space, can you name the component of masticator space?
Sorry, ma'am.
Can you name the components of the masticator space? You mentioned masticator space, and how is it different from the ITF?
So masticator space will actually, masticator space is the deep space within the boundaries would be the fascia overlying the masseter muscle and the fascia medial to the medial pterygoid muscle. So it would basically contain the muscles of mastication. And then the mandibular nerve.
Correct.
And internal maxillary vessels.
And you mentioned high ITF. What is high ITF, low ITF, and what is the significance in response?
So radiologically, it is based on a horizontal line that is passing through the sigmoid notch. So if the tumor is crossing beyond that horizontal line, we call it as a high ITF involvement. The significance is that the difficulty in getting the margins. So the high ITF tumor in a T4B, high ITF involvement would be considered as a technically unresectable lesion.
Why is it considered technically unresectable? What is the distance of the notch from the skull base? Average distance of the notch from the skull base?
Average distance of notch from skull base is approximately, no sir, I'm not sure of.
So it is around 1.4 to 1.5 centimeters. So that is why disease extending beyond a 1 centimeter clear margin is difficult over there.
Yeah, okay, sir.
Reshma, what's the attachment of the temporalis muscle on the mandible?
So it inserts onto the coronoid process of the mandible.
And is involvement of the point of insertion of temporalis unresectable?
Point of insertion, it would not be deemed as unresectable because we can get a margin at the temporalis muscle by making a higher cut.
But that is supranotch.
That is supranotch. So it is just technically unresectable. It is not like purely unresectable.
Can you name it?
There could be a chance of leaving behind some tumor and chance of recurrence in such cases. So we should be very cautious with that.
So I think even literature supports that high ITF is not unresectable. And I just gave you an example where it's not. Clearly, you would all agree it's resectable, right? High ITF is poor prognosis. And as you said, difficult to get margins. But every high ITF is not unresectable.
It's not yes.
Right? I mean, involvement around the coronoid is a good example of supranotch, but clearly resectable.
Yes.
Same way, if the underside of the lateral pterygoid is involved, which is a supranotch structure, because the lateral pterygoid essentially runs above the notch. But if just the undersurface is involved, you can resect the lateral pterygoid and get a great margin.
Yes,
Only
agreed.
when it's through the bulk of the lateral pterygoid that you can't get a margin.
Mm.
So supranotch, you look at Lyos paper, you look at anything, it tells you it's poor prognosis.
Mm.
Not all supranotch is unresectable.
Mm.
And what's your thoughts on infranotch tumors being classified as T4B? Do you have any thoughts on that? Is that appropriate, inappropriate? What are the changes we've seen in TNM over the years with regards to masticator space involvement and its classification? Maybe my question wasn't clear.
Mm.
So, how do you rate infranotch infratemporal fossa involvement vis-a-vis resectability and prognosis compared to other T4 tumors of the oral cavity?
So infratemporal fossa disease, one way we classify them as high ITF and low ITF. And the high ITF can still be anterior tumor and as well as a posterior tumor. So anterior tumor would be something which is extending through the posterolateral wall of the maxillary sinus. And posterior disease would be something which is extending through the pterygomaxillary fissure and the pterygopalatine fossa, that region. So that posterior ITF should be considered as technically unresectable, but anterior ITF should not be considered unresectable, as you have just said. I think it is little surgeon dependent. It would be possible to obtain a margin in the anterior ITF. So regarding considering it as T4B, I don't think I'm at a point to make a comment on that.
Yeah, I think maybe the point I wanted to drive was, I think it's your paper from Tata itself that said that
Yes.
infranotch T4B does as well as T4A.
Yeah, it does.
So probably that's a bit of an overstage for it today. Putting down the low infratemporal fossa tumor as a T4B is probably a bit of overstage. At least they seem to do fairly well. But anyway, that was the point I wanted to ask. It's common sense, like you have a little bit of ramus mandible involvement. That's infratemporal fossa. You have a little bit near the ramus,
Yes.
lower end of the medial pterygoid. Technically, that's all infratemporal fossa.
Yes.
But clearly, we all would agree that's highly resectable with a reasonable prognosis if you get good margins.
When will you consider NECT in ITF involvement?
In ITF involvement. So if there is high ITF involvement and we would feel like we won't be able to get a margin, then we may consider the possibility of NECT. But at present, at this point, considering NECT is not a standard of care. It is purely investigational. So
I have a tumor which is going right up to the skull base, eroding the skull base. Would I give NECT in that patient? You mentioned high ITF.
Then if there is high ITF involvement reaching to the skull base, I would still give the possibility of, I would want to consider NECT in that patient and see if the tumor is responding.
Does frank erosion of the skull base, you would give NECT?
Erosion of skull base? No. Erosion of skull base, then no. If it is high ITF, then yes. But something with the involvement of the foramina or erosion of the skull base foramina, then no. I would consider it as unresectable.
It's only if it is borderline resectable. It is just extending maybe to the lateral pterygoid like Dr. Deepak was suggesting, and you expect to get clear margins after
NECT.
Any paper you are
Yes, yes, from TMH itself, we have 3 papers, one by 2 papers by Patil sir and 1 paper by Joshi et al. So Patil sir, it was a prospective study where we included all the borderline resectable tumors. So the borderline resectability was defined in that paper as something which is extending into the high ITF or any anterior to third tongue tumor extending till the vallecula or reaching till or beyond the hyoid bone. When there is a peritumoral edema reaching up to or beyond the level of zygoma, and when there is extensive skin infiltration, extensive skin involvement precluding a resection. So all these were considered technically unresectable in that paper and were given the option of NECT. So 3-drug regimen as well as 2-drug regimen were tried, TPF as well as PF. So with the three drug, we were able to, so 43% of the cases, we were able to resect after giving NECT, and all the resections were R0 in that paper.
Okay, I would like to ask the moderator, can we proceed? Do we have time, or shall we try to wrap it up? Because we have so many questions coming up, and this is just going to
Yeah, we are actually short on time, so we can further proceed towards the eventual management and summarizing the entire thing.
So Reshma, do you have the imaging up?
Yes, sir, I do have.
Can you quickly tell us your findings of the imaging?
So I would show this imaging. So this is a contrast enhanced CT scan of the head, neck, and then thoracic cuts are also there. So we can see a heterogeneously enhancing soft tissue lesion in the upper gingivobuccal sulcus, abutting onto the maxillary alveolus, and posteriorly reaching up to the retromolar trigone. Also, it is abutting onto the masseter posteriorly, and also some loss of fat plane with the medial pterygoid, which I am suspecting. And very close to the skin, I can see fat strandings here. And then as we go down, there were nodal involvement in the, multiple enlarged nodes were seen in the right level 1B as well as level 2 were seen in the scans, but level 2, I'm not sure of the significance. The level 1B node, the maximum size was 2.3 centimeter in that scan, and there was evidence of necrosis in that. But the borders were all distinct, and there was no contrast enhancement irregularity in the nodal border. So radiologically, I do not think it has an extranodal extension, but the node look involved. And there was no extension into the ITF. Then in the coronal cuts, the fat strandings were extending till somewhere here, this point.
Sorry, you said no extension into the infratemporal fossa.
High infratemporal fossa.
High infratemporal fossa.
Also, there was no bony erosion also, as per the scan in the bony cuts.
I think it is just extending into ITF. It's barely extending into the ITF. Even the retroantral fat pad is completely maintained. Just I think the pterygoid, just few fibers of it seem to be involved.
Okay. What's your management plan?
So this being a locally advanced disease, I would like to, my treatment intent will be curative. I would like to go ahead with a multimodality therapy in the form of primary surgery, which would entail a right infrastructural maxillectomy plus a marginal mandibulectomy and modified radical neck dissection levels 1 to 5 clearance with a consent for tracheostomy, followed by a microvascular free flap reconstruction. This would be my primary surgical plan, followed by adjuvant radiotherapy or adjuvant chemoradiotherapy based on the final histopathology feature. If there is any evidence of extranodal extension or microscopic positive margin, it would be adjuvant chemoradiotherapy, or else it would be adjuvant radiotherapy. Adjuvant radiotherapy would definitely be there, considering the T4B.
Why marginal mandibulectomy?
So, ma'am, radiologically, this was reaching till abutting till the masseter, and I am doubting a loss of fat plane with the medial pterygoid also. So it is reaching till the RMT. So I would want to take a margin there. So I would prefer to do a marginal mandibulectomy.
Great.
Reshma? Sorry. Ravi,
Sorry, please go ahead, sir.
My only thought is, I am not sure you'll get a great margin with a marginal here. My thought would be this patient probably needs a segmental. But I'm not going to debate with you surgical skills. We all have different levels of surgical skills. But I think you need to clear the infratemporal fossa fairly well here.
Yes.
You need a reasonably high cut on the maxilla. You'll want to get the pterygoid plates out. You'll definitely want to get the pterygoid muscles out.
Yes.
And it is difficult to do that through a marginal mandibulectomy. You can do a very limited ITF resection, but you can't really do a very complete ITF resection. So for me, at least in this patient, I think I would plan a segmental that gets our entire muscle bellies, medial and lateral pterygoid, the entire muscle belly comes out, and you get a good sort of resection around the tumor. I think marginal you'll struggle, but and a modified neck. What incision would you use?
So the tumor being very close to the skin, I would take a.
You did mention skin resection here?
Yes, skin resection will be there. Right. So that so I would plan a skin resection and I would extend it to the commissure. So I think the commissure, right lateral commissure might also have to be taken out with the specimen, a part of the right commissure, because the tumor induration clinically was reaching till the commissure. So I will extend my skin excision to the both commissure, and I would plan a separate neck incision.
A separate neck incision. So you don't want to raise the cheek flap here, you mean? So you mean a horizontal neck incision?
No, sir. So from the skin plan, I would extend my incision down to the neck.
Right.
And then raise the neck flaps and do the neck.
Right. In a patient where you're resecting a lot of skin on the face, and aesthetic placement of the incision is of very little concern.
Yes.
So yeah, maybe a single vertical drop down or whichever way you want to take it, but you need to raise a cheek flap here. So therefore
Dr.
you would
Deepak,
need to
I'm
take it
sorry
down.
to interject, but we are already running late. We are 5 minutes over the time.
We are way ahead of our time. I think we should mark and we should bring it to a conclusion, because the organizers, they are really want to be on time.
Sure. No, I think you did very well, Reshma.
Thank you, sir.
Well done.
So,
Dr. Ravi, your comments for Reshma?
actually, she has defended every answer very well, and actually every question very well. And only thing is, I think she needs to read a bit about the anatomy of infratemporal fossa and understand the intricacies of infratemporal fossa in clinical decision making. Other than that, I think she has done fantastic and fantabulous. I would definitely pass her, and I would give somewhere around 8.5 out of 10.
Thank you, sir. I'm sure I'll read, sir.
Great. Thank you all. Thank you, Reshma. Back to the organizing team, please.
Thank you.
Thank you.
Thank you, Reshma, and the expert panel for this enlightening discussion. I'm sure all of us here in the audience now have a clear understanding on the various clinical scenarios and the management of a case of carcinoma of upper GBS and alveolus. So moving on to the second session for today, it's on radiological anatomy of upper alveolus and maxilla. The expert panel for this session is Dr. Vidisha Tuljapurkar ma'am. She is Associate Professor in Department of Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. And Dr. Amit Janu sir, he is Professor, Department of Radiology, Tata Memorial Hospital, Mumbai. The presenter for this session is Dr. Kajri Bhattacharya ma'am. She is Associate Professor in the Department of Radiodiagnosis and Imaging, Tata Memorial Center, ACTRAC. I hand over to Dr. Kajri ma'am to proceed with her presentation.
So good evening, everyone, and I welcome our expert panelists to chair this session. The topic of discussion is radiological anatomy of maxilla and upper alveolus, and the aim of my presentation is to describe the relevant anatomy and radiology of maxilla and upper alveolus lesions, which generally present as oral cavity masses. And my emphasis will obviously be on squamous cell cancers, as they are the predominant masses that we see in our OPD on day-to-day basis. So I'll be discussing three subsites mainly, hard palate, upper alveolus, and maxillary gingiva, along with the upper GBS. So coming to the role of imaging, so extremely important in loco-regional staging, and what the technique which we use in upper GBS as well as maxillary lesions is most commonly a CECT with a puffed cheek technique. This is the standard of care which we use, especially for gingival and alveolar gingivo-buccal carcinomas as well as the alveolar squamous cell carcinomas. They are generally acquired in an axial plane with thin slices of 0.625 to 1 millimeter, and then they are reconstructed in coronal, sagittal, and oblique planes. And it is extremely important, which I'll show in my future slides, that why is this reconstruction important. Again, we have to see the tumor in the bone as well as soft tissue algorithms. And as we all know, bone erosion is much better appreciated in CT in bone windows, and therefore it is important. Again, as reiterated in the previous presentation, I'll be saying that perineural spread is much better appreciated on MRI, especially if it is a subtle one. And smaller lesions of palate, or for that matter, smaller lesions of any of these regions can be sometimes better appreciated on MRI. But for all practical purposes, for perineural spread, MRI is considered to be most sensitive. So giving an example of this puffed cheek technique, so we can see two CTs side by side. So first one is a non-puffed cheek, second one is a puffed cheek. So we can appreciate here that the vestibule is quite well seen in the
puff cheek study. And whenever we have a very small lesion as seen in the right buccal mucosa lesion, as in this case, it is only appreciated in a puff cheek study and it cannot be appreciated in a non-puff cheek study. Similarly, it will stand true for the lesions which are on the alveolar margin on the outer side facing the vestibule. So these lesions can only be appreciated in a puff cheek study. So coming to the anatomy of maxilla proper. So maxilla is a pyramid-shaped bone and it has 4 processes. The first is the nasal process. Second is the zygomatic process. Fourth is the alveolar, and third is the alveolar, and fourth is the palatine process. And there are multiple fissures which are foramina which are present in the maxillary bone, which traverse various branches of maxillary division of the trigeminal nerve, and they come in relation with various tumors, and as we will see in a few in the examples in the future slides. So let's come to the relevant radiological anatomy. The first subsite to discuss is the hard palate. So as we can see here in the actual diagrammatic representation, the hard palate is formed by the horizontal plate of the palatine bone and the palatine process of maxilla. And there are two important, a pair of important foramina which are present on the posterior aspect of the hard palate and a central incisive canal which is present on the anterior aspect. So when we are seeing the CT, it is the hard palate is seen best in the coronal reconstruction images. So as we can see here, this is the soft tissue window and this is the bone window. This is actually a left lower GVS lesion, and this can also actually elicit the role of this puff cheek better. So as we can see here, but I'm not concentrating on that. So what we are seeing is basically the palate. As we can see here, this is the mucosa of the palate, which is quite symmetrical on both sides. And this is the bone window, which shows that there is absolutely normal bone window. Along with that, we are seeing the upper alveolus as well as the upper gingival-buccal sulcus. So coronal plane is extremely important when we are looking at the maxillary lesions. Coming to this retromolar trigone. So whenever we have a lesion which is located in the upper alveolus and located quite posteriorly, the relationship with the retromolar trigone becomes quite important, because retromolar trigone, which lies behind the third molar of the maxilla as well as the mandibular, this region, this through the pterygomandibular raphe comes in direct connection with the pterygopalatine fossa, and any disease which is present there can go to the infratemporal fossa superiorly as well as into the pterygopalatine fossa. So if we see the routes of spread of disease, it can go obviously into the alveolus, laterally into the buccal mucosa, posteriorly into the masticator space, posteromedially into the tonsil, and posteriorly in the tongue. And obviously, it can go more superiorly into the infratemporal fossa, and from there, it can involve the skull base, especially the pterygopalatine fossa. Now, coming to the infratemporal fossa, as we have extensively discussed in our previous presentation. So the masticator space and infratemporal fossa are slightly different spaces. So the masticator space is delineated by this slight blue line, which is covered by which the deep fascia which engulfs the muscles of mastication and the ramus of the mandible. So laterally lies your masseter muscle, as we can see here, and medially on a lower plane lies the medial pterygoid muscle. Superiorly lies the lateral pterygoid muscle. And here, as we can see here, this is basically at the level of high ITF, we can see the temporalis muscle. So these forms the part of your masticator space. However, the infratemporal fossa has a slightly different boundary. So it will not include the body of the mandible, the ramus of the mandible, the major part. So basically, it starts from the medial aspect of the margin of the mandible. So it excludes the masseter muscle. However, it includes the retroantral fat as well as it extends till the parapharyngeal space, prestyloid parapharyngeal space. So it basically, it again is divided into the infranotch and the supranotch ITF. So it is by the sigmoid notch of the mandible, as we can see here. So whatever is supranotch is considered as the high ITF. So as in this case, we can see the right side is normal, left side, there is some disease in relation with the low ITF, which displaces the retroantral fat and maybe is in contact with the medial pterygoid muscle also. That we need to see that the high ITF of this is also not involved. So this is considered as a resectable disease. Coming to the anatomy of maxillary sinus proper. So maxillary sinus has 6 walls. The first one is the superior wall, which is delineated in green, which comes in relation with the inferior wall of the orbit. Next is the lateral wall, which is delineated in yellow, and it is also actually the posterolateral wall. So what happens is, if we have a lesion in the upper GVS, this comes in direct contact with this wall of the maxillary alveolus. And also, if we have a posterior lesion, which is related to the retromolar trigone, then what can happen is that
The disease may extend into the retroantral fat and can invade the infratemporal fossa. So this wall is very important. We have to look for subtle erosions of this wall. Next is your posterior wall. So posterior wall is a very small wall, but it is a very, very important wall because it comes in a relation with the pterygoid plates and the pterygopalatine fossa. And this pink arrow shows the pterygomaxillary fissure through which it connects with the pterygopalatine fossa. So the posterior wall is a small but a very important wall. Medial wall is seen in this light blue arrow, which actually forms the lateral wall of the nasal cavity. And is the inferior wall, basically, which forms the maxillary alveolus, and any alveolar lesion can actually directly go to the maxillary sinus through this route. Now, coming to the description, anatomical description of various skull-base foramina. Now, this is extremely important for us to understand because the lesions of the palate and the upper alveolus as well as the upper GBS, they come very close to the infratemporal fossa. And therefore, there are multiple structures which can actually go through perineural spread through these foramina. So, for example, the first foramina that we see here is the greater palatine foramen. So, as I already discussed, it comes in relation with the posterior part of the hard palate. We have to look for symmetry of this greater palatine foramina on both sides. I'm sorry, my pointer is not available. Yeah, okay. So, we have to look for the symmetry on both sides. And on contradistinction to it is the central incisive canal and foramina, which is again seen in this central part of the palate anteriorly. So this one, which is encircled in red, basically contains the greater palatine foramen and the lesser palatine foramen, which is magnified and shown in this particular image. The greater palatine foramen is and the lateral palatine foramina can be well identified. And from there, they go in directly into the pterygopalatine fossa. So therefore, it is important to identify any disease causing erosion of these regions. Coming to more superior cuts, so here we see the bony window showing the pterygopalatine fossa. So this is basically your pterygomaxillary fissure, which is delineated with the green arrow. The red one shows the pterygopalatine fossa, and this comes in relation with the posterior wall of the maxilla, and posterior to it are the pterygoid plates. So this anatomy is again very important to see that whether there is any soft tissue present here or not. Again, this again shows the sagittal reconstruction where we can appreciate the entire extent of this teardrop shaped structure, which is basically your pterygopalatine fossa, and greater palatine foramen canal can actually go and directly disease can extend into there. Coming more superiorly, again, the superior part of the pterygopalatine fossa, here we can see one canal which is actually going just posterior to it. And from there, it communicates with your middle cranial fossa, which is called as the Vidian canal. And more superior cuts show at the level of inferior orbital fissure. There's again, inferior orbital fissure connects with the pterygopalatine fossa, and from there, it enters into the middle cranial fossa at the level of foramen rotundum. So this is basically a lower cut. This is a higher cut, but this can be actually separately identified. So foramen rotundum is the superior one, and the lower and medial one is the Vidian canal. So the disease along the maxillary division of the trigeminal nerve can directly enter into the middle cranial fossa along these foramina, and these should also be tried to identify when we are expecting any perineural spread. This light blue arrow delineates your infraorbital foramen from which the infraorbital nerve can traverse along here to the inferior orbital fissure, and from there intracranially. Lastly, coming to the identification of foramen ovale. So this is the most easily identified foramen on the skull base when we see our scan. So this is seen in the axial sections of the CT as these oval-shaped foramina. And in the coronal reconstruction, we are seen directly entering into the Meckel's cave region. And again, we have to see the similar features, whether any soft tissue involvement or any bone erosion is there in these regions. And again, obviously, when the disease reaches through the skull base through this foramina, it becomes an inoperable disease. So now I'll be showing representative cases of involvement of various areas by the upper alveolus diseases. So this is the first case. It's a 41-year-old male who is a known tobacco chewer for 20 years and who has presented with an ulcer in the right cheek for 1 month. So what we're appreciating here in the coronal scans is basically this upper GBS lesion, which is extending to the buccal mucosa. There is involvement of the subcutaneous fat. Along with that, we can see, so whenever we are doing a the CCT, we have to see the amount of enhancement. So whenever we are seeing it is in relation with the maxillary sinus, we generally see this kind of maxillary sinus thickening, but we should not confuse it with the disease because this part is not showing any enhancement or any bulge kind of thing. So this is basically just a reactionary maxillary sinus wall thickening. And in such cases, we have to be very careful to look for any subtle bony erosion. We should look for that in bony cuts in all three planes. So this is the same patient's image. We can see here the disease extending up to the retromolar trigone. And but however, the superior fat is very nicely seen. So the pterygopalatine fossa is most likely not involved. We can see the involvement of the masseter muscle and the medial pterygoid. So therefore, the low ITF is involved. However, there was no involvement of the high ITF. There may be a subtle erosion of the posterior wall of the maxillary sinus. However, the pterygomaxillary fissure and pterygopalatine fossa were fine. And obviously, this patient has a 1B node, which has some necrosis, and it is abutting the platysma muscle on the right side. So this is how we can see the loco-regional disease extension in this particular case. There were no other nodes. There was no extension into the ITF. So this is a pretty resectable disease. Coming to the second case, so this is a 43-year-old female who has a history of tobacco chewing for 15 years, and she has presented with decreased mouth opening since 4 months. So we can see here that there is an ulcero-infiltrative lesion which is present in the hard palate. So this is the proliferative component is very less. So what we can appreciate in the bone window is that there is significant erosion of the hard palate in this region, which is with the disease abutting the nose as well the nasal mucosa, as well as the alveolus is also partially eroded in this case. Posteriorly, in the sagittal sections, we can appreciate that the disease is possibly involving till the soft palate. So that part is also involved. Coming to the further locoregional disease extension. So when we move more posteriorly on the coronal image, here we can appreciate the greater palatine foramen in its entire extent. However, here we can see that the disease is actually involving and eroding the greater palatine foramen on the right side, which is delineated by this right arrow. Going more superiorly here, the disease is probably extending till the lower part, but obviously there is the fat at the upper part of the pterygopalatine fossa is maintained. And if we are actually suspicious of any perineural spread, we can actually order an MRI in this particular case to rule out any perineural spread. Again, the lower part, we can see that there is involvement of the greater palatine canal. The medial pterygoid plate is partially eroded, which erosion is not seen in the more superior sections. And at this level, the pterygomaxillary fissure, as well as the pterygopalatine fossa, look fine. And again, we can appreciate in this case also that there is involvement of the retromolar trigone and the medial pterygoid muscle. So this is how we locoregionally see the disease extension, particularly in this patient, obviously, because this is a primarily hard palate lesion. There was no nodal. I'm so sorry. There were nodal metastasis. So this possibly is because there is involvement of the alveolus also. So we can see 1B level necrotic node, and there is another large node which is present at level 2 with possible extranodal extension also. Coming to case number 3, so this is a 45-year-old male who has presented with an ulceroproliferative growth of the left buccal mucosa, who is a long-standing tobacco chewer. So in this case, what we are seeing is this is a much more extensive disease which is extending from the upper GBS to the lower GBS, and involvement of the buccal fat pad is also seen. The interesting point in this case is this is a more anterior disease, and whenever we are having a more anterior disease, we have to look for certain other things. So here we can see that the infratemporal fossa is practically not involved because there is no obvious retroantral disease, and there is the masticator muscles as well as the pterygoid muscles appear grossly free. In the bony window, we can appreciate the alveolar erosion. But in this particular case, we have to see that there is any edema reaching up to the level of zygoma, because in that case, to achieve a surgically negative resection margins becomes a bit difficult. So this is an indication of starting a neoadjuvant chemotherapy. We see there is edema reaching up to zygoma. In such cases, we have to also see that if there is only edema or then disease is also there. So in this case, there is no disease and the infraorbital nerve looks fine. So this is what we have to look for when we are looking for more anterior diseases. And obviously, this patient also has a large nodal burden at level 1B on the left side, and level 1A nodes are also involved. And in this particular case, since it's a large node and with extranodal extension, we should try to look for this fat plane between the hyoid muscle, because if this is not there, then the disease becomes again difficult to resect. Coming to case number 4, this is a 48-year-old male who is a tobacco chewer since 20 years, and he has a right-sided ulcerative proliferative growth in the oral cavity. Now, this is a more quite extensive lesion where we can appreciate that this is a heterogeneously enhancing lesion which is present involving the upper alveolus, involving the part of the nasal cavity also. And we can see it reaching up to the half of the maxillary sinus. The rest of it is collection. So whatever is enhancing is this is the entire extent of the tumor. Again, we can appreciate here that the greater palatine foramen on the left side is fine, whereas right side there is gross erosion, and we have to be careful about the perineural spread. So when we see at the sections of the pterygopalatine fossa, we can see again that the lower part maybe some fat plane loss is there, but grossly the pterygopalatine fossa looks fine. When we look at the other extensions of the disease, we see that maybe there is some disease in, there is obvious disease which is entering into the nasal cavity, but some disease may also be there, some erosion may also be there along the posterior margin of the alveolus, and therefore bone window should be carefully looked at, sorry, not the alveolus or maxillary sinus. And there is some effacement of the retroantral fat also, so we have to be very careful about the involvement of the pterygomaxillary fissure, and from there, disease entering into the pterygopalatine fossa. Again, since there is some disease in the anterior wall also, we should look at the infraorbital nerve. Here we can, in the bony window, we can see the gross erosion of the alveolus, and there is a small 1B node and on the right side. Case number 5. So this is an elderly male. It's an 84-year-old male who has ulcer over left cheek since 1 year, with pus discharge from the wound since 4 to 5 months. So now this is a very extensive disease. This has been a long-standing disease, and it's a neglected case. So here what we see is that the entire left cheek has this soft tissue. So there is disease, ulcero-infiltrative disease, which is involving the left maxillary sinus. It is extending into the masticator space. It is extending up to the skin. So therefore there is gross erosion in this case. So when we see the axial sections, we see there is gross erosion of the pterygoid plates. We can see here the pterygoid plates are seen on the right side, the pterygoid plates on the left side appear eroded. There is involvement of the disease in the pterygopalatine fossa. So the entire area is replaced by your disease. We are not able to identify any muscles of mastication. So the infratemporal fossa and the masticator space appear involved. The disease is in fact reaching up to the skull base. So this is obviously an inoperable disease. We can see actually it is eroding the foramen ovale and it is reaching up to the foramen lacerum, which contains the internal carotid artery. The parapharyngeal space also on the right side is well identified, which is effaced on the left side. And here again, this is just to show the example that the Vidian canal on the right side is seen, on the left side it is eroded. Whereas the foramen rotundum is seen nicely both sides. Coming to the penultimate case, so this is a 43-year-old male who is a chronic tobacco chewer for 15 years, who presents with ulcer in the mouth since last 1 month. And this case is basically an MRI has been done. So I'll just elicit how MRI is helpful to us in these cases. So it is extremely important that when we are looking at MRI, we look at the T1 images. Why? Because in head and neck, what we see here is that the fat provides a natural contrast between the soft tissue structures, and when the fat is displaced in a particular region, which is asymmetry, then and when there is asymmetry between both sides, we can say that there is involvement of that area. So for example, this is an upper alveolus lesion which is invading into the maxillary sinus, and it is also involving the palate. Here we can see that the greater palatine canal is nicely identified and the fat is nicely preserved. However, on the right side, the fat appears to be displaced. So again, showing the importance of the T1. So here we can see there is soft tissue which is going into the retroantral fat. So this is also involved. However, if we look at the pterygopalatine fossa, the fat is very nicely seen. So therefore, the pterygopalatine fossa is definitely not involved in this case. And therefore, MRI gives us exquisite details, especially your non-contrast or a pre-contrast T1 about whether the disease is present in a place or not. In post-contrast also, no such disease is seen, and there is a node with the necrosis, as we can see at level 1. Coming to the last case. So this is a 30-year-old female who is a known case of adenoid cystic carcinoma of hard palate who underwent resection wide local excision elsewhere in 2011. So what we can see, there is a defect of the hard palate on the left side, and there is no obvious disease identified locally. This patient was on an irregular follow-up. So in 2016, what we can see here is, this is the region of your greater palatine foramen, where we can see that there is definite widening of the greater palatine foramen and asymmetry on the left side. The right side appears to be normal. Actually, when we went through, so this patient came in a follow-up after 2011, in 2013 and 2016, and there was possibly subtle asymmetry in 2013 also, maybe it was not, the patient did not do a regular follow-up, and no treatment was offered because she was not very keen on it. But however, we can see that this was still involved in 2013. And finally, when the patient came for a follow-up in 2020, she also had lung metastasis. We can see there is definite involvement of the pterygopalatine fossa where it is extending to the skull base. So this shows how MRI can actually give us the extent of perineural spread very nicely. So with this, the take-home message is that role of CT is very important. So basically puff cheek studies done. Most often it is used in all subsites, and bone erosion is better seen in CT. Widening of the bony canal is important in perineural spread. However, for perineural spread, MRI is a better technique because it shows subtle perineural spread also, and small mucosal disease can also be seen better in MRI. For us, T1 non-contrast, non-fat set MRI, that is pre-contrast non-fat set MRI is extremely important because it provides a natural contrast of suspicious soft tissue against the fat to rule out subtle disease involvement. And this should be followed by a post-contrast T1 fat set imaging. Thank you. I would request the expert panelists to give their comments on the presentation.
Excellent talk. I congratulate you on the talk. I just would like you to tell for the benefit of residents who are present here regarding the excellent CTs that you showed about the various foramina. Could you?
It seems that you are logged in with two gadgets, so that is why it is echoing.
Okay, is it better now?
This is better. Perfect.
Sorry. Yeah, because I'm having some connection issues, I guess that is right. Yeah, so Kajri, I would like to request you for the residents' benefit, if you could just tell the anatomical landmarks for identifying various foramina in a CT scan. So like you showed initially about various foramina for the residents' benefit. And
so I will again repeat it, ma'am.
For an MRI.
Sorry, ma'am.
And when would you particularly ask for an MRI when you have perineural spread?
Okay. So let's first start with the anatomical description. So first, the foramina which we identified on the palate are these greater palatine and lesser palatine foramina and the incisive foramen, which is incisive foramen is a midline single foramen which is present in the anterior part at the junction of two halves of the hard palate, and it transmits the sphenopalatine artery and the nasopalatine nerve. And if the disease is present in the anterior part of the palate or anterior part of the alveolus, it can actually go into the nasal cavity through this. Whereas when the disease is located on the more posterior part or it's a bulky disease, we have to be very careful to look for the involvement of the greater palatine canal, which is very easily identified on these coronal sections. So as we can see here, these are the greater palatine foramen and canal. Here the fat, we should actually look for the soft tissue window as well as the bony window. The bony window is particularly important to look for any bony erosion. So this greater palatine canal, as we can see here in the coronal image, are seen in this way. Whereas if we look at the same, we see here on the posterior part of the palate, just adjacent to the medial pterygoid plate, this is the greater palatine foramen and these are the lesser palatine foramina. So again, this is a zoomed in view where the greater palatine foramen and the lesser palatine foramina are seen. So this greater palatine foramen directly is in communication more superiorly with the pterygopalatine fossa. So the pterygopalatine fossa, as we see here, is the structure, is the space which lies posterior to the small posterior wall of the maxillary sinus and anterior to the junction of the pterygoid plates. It is in communication with the infratemporal fossa, as we see here, with the pterygomaxillary fissure. And whenever there is a high ITF disease or a disease involving the lateral pterygoid muscle particularly, and it reaches up to the pterygomaxillary fissure, it becomes a very difficult resection margin, and we have to be careful about the disease extension into the pterygopalatine fossa. The pterygopalatine fossa is actually this teardrop kind of structure, which is more wide as we go more superiorly. And here we can see the communication of the greater palatine canal leading into the pterygopalatine fossa. So as we move more superiorly, we can see here the pterygopalatine fossa again. And there we can see the communication with this canal, which is a more lower and medial canal, which is the median canal. Whereas if we go more superiorly, we see here this canal, which is basically the foramen, which actually is the foramen rotundum, and it communicates, both of these can communicate with the middle cranial fossa. And other than that, we see this infraorbital foramen, which again is it communicates with the inferior orbital fissure and from there into the pterygopalatine fossa and into the middle cranial fossa. So this can be separately identified very nicely in the coronal view. The median canal is the lower and medial one, and the lateral one is the foramen rotundum. Lastly is the foramen ovale. So the foramen, here we can see the median canal. So the foramen ovale are these, we see the cross sections of these foramen ovale when we are seeing in the skull base, and in the coronal view, we can see them in the longer sections. It is important again to identify any bony outline. Specifically to your question, madam, that why we should do an MRI, when we should do an MRI. So for example, if we have a disease which is reaching to any of these cranial nerve foramina, when we are and we are clinically suspecting any cranial nerve involvement on our clinical examination, and obviously if we are seeing any displacements of in CT, what we see in case of perineural spread is basically the loss of fat plane along that foramina. So fat plane is very easily seen in CT.
Okay.
If in that case, we are suspecting that there is any suspicious bony involvement and there is no gross bone erosion, then it is better to obviously do an MRI to see any subtle spread, perineural spread into the intracranial cavity of the skull.
Just to add what Kajri has spoken about, this is not the usual presentation that we would see in department. Most of the time, these images are very blurred, thick sections, no bone window images. And then at that time, it is very difficult to evaluate these foramens. Second thing about the perineural spread, that it can spread from the nodes also, and it can have skip metastasis. So we have few cases in which there is a beautiful surgery has been done, and just after the surgery, the patient either developed ptosis or had some hearing loss because the perineural spread has been missed. So these are the rare scenarios in which we can see these changes. So Kajri, alveolus.
Sir, you are muted, sir.
Sorry. So alveolus is something which is we will see that it is in the middle of thing. If we go laterally, we will do CT. And if we go medial to the alveolus, we will do MR. So where does you think that it is ideal to do an CT in case of alveolar lesions, or it is better to do an MR?
So whenever we are looking at lesions which are in the vestibule, so whenever we are looking at the lesions of the upper alveolus as well as the vestibule, so upper gingivobuccal sulcus when we are seeing. So in that cases, I would prefer to do a CT. Whenever we are seeing lesions of the hard palate, especially because this is the area which is intensive in your foramina. So for example, we have the greater palatine foramen, we have the greater palatine canal, which can directly lead into your pterygopalatine fossa. In those cases, I would prefer to do an MR. So for example, if we are seeing a lesion of a hard palate, which is in abutting any of these canals, then we should preferably do an MR. So I would also like your expert opinion on this.
Yeah. So definitely, if we are suspecting towards the side of GLS, we will prefer that it has to be evaluated with the MR. If it is toward the side of GBS, it is better that we will evaluate with the CT.
Yes,
yeah.
Also, sir, ITF involvement in case, let's say, case of CA maxilla or upper GBS, would that help to do an MRI to better delineate the involvement of the muscles in that case?
So generally, ma'am, when the fat plane is lost, it is very well seen on CT also. So if we are still very close to the, if there is an obvious, so first thing is that first we have to see whether the disease is in the anterior ITF or the posterior ITF. So if it's only involvement of the retroantral fat, and there is no obvious involvement of the posterior ITF, the fat planes between the muscles are well maintained, then we don't need to do an MR. Obviously, if you have a disease in the high ITF, which approaches very close to the pterygomaxillary fissure, it is involving the lateral pterygoid grossly, then when we can obviously consider doing an MR, considering its significant spread to the pterygopalatine fossa and the other cranial nerves.
Right. Thank you, Doctor.
Second thing
Kajri
is that,
and Amit,
yeah.
Because this is a postgraduate program, one thing that I would like to both of you to very clearly say to the postgraduates, many a times a patient already has a CT scan, and a good CT scan it's a contrast enhanced CT scan. Yet people have the misnomer to do another MRI or another set of investigation. So do you encourage that if you have a good contrast enhanced CT scan, for example, they feel that for soft tissue delineation, we must do MRI. For nodal metastasis, we must do MRI. Is the CT scan sensitivity, specificity so low? And what additional value the MRI will give when you have a good CECT?
So, sir, it is very clear that something which is lateral to the alveolus, or especially for the vestibule, whether it's a buccal CA, lip CA, or any other CA, CT with the MDCT, having a multiplanar detector with 1 mm sections, which can be done in the multiple sagittal and coronal reconstructions, CT is excellent. So we don't do MRI in those cases. Something which is for tongue, soft palate and hard palate, MRI is better. So if we have to divide our oral cavity proper in such a way that what is inside the alveolar margin is evaluated with the MRI, what is outside it is evaluated with the CT scan.
So with this, if there are no more questions, I would like to finish the presentation. Thank you to the expert panelists for their comments.
Thank you, Dr. Kajri. Excellent presentation.
Thank you. Thank you.
I guess we'll hand it over to the organizers for the next session.
Thank you, Kajri ma'am, and the expert panel for this excellent and detailed discussion, which highlighted the key features of the radiological aspects pertaining to a case of upper alveolus, as well as the relevant regional anatomy. So moving on to the third session for today, it's a video demonstration on the operative technique of neck dissection video. The panel for the session is Dr. Pankaj Chaturvedi sir. He's professor in the Department of Head and Neck Surgical Oncology, as well as Deputy Director, CCE, Tata Memorial Hospital, Mumbai. Dr. Ashok Das, he is professor in the Department of Head and Neck Surgical Oncology, B. Burua Cancer Institute, Guwahati. Dr. Vipin Arora sir, Director and Professor in the Department of ENT and Head Neck Surgery, University College of Medical Sciences and GTB Hospital, Delhi. And Dr. Arjun Singh sir, he is Assistant Professor in the Department of Head and Neck Surgical Oncology, Tata Memorial Center, ACTRAC. The session will be moderated by Dr. Burhanuddin Qayumi. He is Associate Professor in the Department of Head and Neck Surgery, Tata Memorial Center, Muzaffarpur. The video will be presented by Dr. Jitendra Sharma, MCH Resident at Tata Memorial Hospital. I would now hand over to Dr. Jitendra to commence with his video demonstration.
Hi, Jitendra.
Good morning, everyone. So, good evening, everyone. Today's this session is on surgical techniques of neck dissection. I will present my video.
Jitendra, can you speak a little loudly or closer to the mic?
Yes, sir.
So while Jitendra is loading his presentation,
I'm sharing my video.
Yeah, go ahead, Jitendra. I was saying that all the participants can post their question on the chat box, and all of us will try to give answers to your questions while the presentation is going on. So you don't have to wait till the end.
Hey, sir, should I start, sir?
Yeah, please go ahead.
Yes, Jitendra. Yes.
Okay. So today we will discuss the surgical steps of neck dissection. Neck dissection is a very important part of oncological dissection in head and neck surgeries, because we have enough evidence on this that whether it is a N0 neck or N positive neck dissection should be done in all of the most of the head and neck cancers. So today we'll discuss the comprehensive neck dissection level 1 to 5. Neck dissection involves comprehensive neck dissection involves the resection of level 1 to 5 lymph node levels, preserving the spinal accessory nerve, sternocleidomastoid muscle, and in IJV. Okay, so neck dissection, from the history point of view, neck dissection, there are a lot of incisions was given for the neck dissection. Some incision were the McPhee incision, lateral utility incision, Hayes-Martin incision, Sobinger, and Kral's incision. Most important incision is the Kral's incision and Sobinger incision. But nowadays, Kral's incision, horizontal limb of the Kral's incision is the most commonly used incision. So here we'll start the surgery with the taking a horizontal limb of the Kral's incision, infiltrating saline adrenaline, 1 in 2 lag dilation. Care should be taken here not to injure the external jugular vein and not to inject the saline adrenaline in the vessels. After giving the saline adrenaline, waiting for some time, then we will give the skin incision. Then we will deepen the skin incision from superficial to deep till platysma. Here we are cutting the subcutaneous fat and exposing the platysma first. After exposing the platysma is cut with the help of knife, and hemostasis is achieved. Here, while we are cutting the platysma in the posterior part, we should take care not to injure the external jugular vein and greater-auricular nerve. After cutting the platysma, the subplatysmal flaps should be raised. The upper flap should be raised till the lower part of the mandible. Anteriorly, the flap should be raised till the lateral border of the opposite belly of the anterior belly of the digastric muscle. And here we should take care in the anterior part that in midline the platysma will be absent. So we should take care in the lower part. The lower flap should be raised till the level of the clavicle, and while raising this flap, we should stay close to the platysma muscle and not take the superficial layer of the deep cervical fascia. In the posterior, while raising the posterior flap, care should be taken not to injure the greater auricular nerve and the spinal accessory nerve, because in the posterior part there will platysma will be absent and we will not be able to identify the plane of resection. The level 1, now we will come to the level 1A resection. The level 1A is bounded by both the anterior belly of the digastric and below it is bounded by the body of the hyoid muscle. First, we'll start the resection by elevating the fascia over the anterior belly of the digastric, getting a plane over the muscles and removing all the fibrofatty tissue from the level 1A area. Here we should take care of the anterior jugular vein and the branch of the submental artery and vein. Coming to the level 1B, level 1B is level 1B is bounded by anteriorly it is bounded by anterior belly of the digastric, posteriorly it is bounded by the stylohyoid muscle, and the superiorly it is bounded by the lower border of the mandible. In the level 1B resection, first step in our resection is to identify the marginal mandibular nerve. We should identify the marginal mandibular nerve. Marginal mandibular nerve usually present at the angle of mandible. From there, it will slope down below the lower border of the mandible. We should identify the marginal mandibular nerve and dissect it in its dissected and keep it in our upper flap. After the marginal mandibular nerve, we should identify the facial artery and facial vein, and delineate the facial artery and facial vein and ligate the facial artery and facial vein. After the delineating the facial artery and facial vein, we should start the clearance of level 1B by separating the submandibular trunk soft tissue from the surrounding structure. First step is to delineate the digastric muscle. while delineating the digastric muscle, we should take care when we come posteriorly, because the facial vein, posterior part of the facial vein will come superficial to the digastric muscle, and we should take care of that. And posteriorly, we should free the submandibular gland from the tail of the parotid area, and there the retromandibular vein can come. So we should take care of not to injure the retromandibular vein, and separate. Then we will separate. We should separate the soft tissue from the mandible, ligating the facial vein. Carefully ligate the facial vein here. This is the posterior part of the facial vein. This is basically a common facial vein. This is formed by the facial vein and the retromandibular vein. After ligating the facial vein, we should start clearing the level 1B. That will be start from the triangle formed by the anterior belly of the digastric and lower border of the mandible anteriorly. We should remove the fibrofatty tissue over the mylohyoid muscle and exposing the mylohyoid muscle. Here, take care of coagulating the branches of submental artery and vein that can be called the troublesome bleeding here. After we'll completely expose the mylohyoid muscle here, mylohyoid muscle will retract the mylohyoid muscle with a loop retractor to expose the three important structures here. The three important structures present in this area is the hypoglossal nerve, submandibular duct, and facial and the lingual nerve. So here we can see that this is the hypoglossal nerve, this is the lingual nerve, this is the ganglion. We can see here. This is the ganglion, and submandibular duct is somewhere here. This is the hypoglossal nerve, lingual nerve, ganglion. This is the ganglion, and here will be the submandibular duct. After proper identification, we should sharply incise the ganglion and clip and either coagulate the submandibular duct, because sometimes some vessel can run along the submandibular duct, so we can use the clips there to ligate those vessels. After dissecting this, the only fibrofatty tissue will be remain, and the specimen is hanging on the posterior part of the facial artery, and we should ligate the facial artery. We usually use the double clamp technique for ligation of the facial artery to be double sure. So after level 1B resection, we should take our focus to the level jugular lymph node dissection, and that is dissection of level 2, 3, and 4. It starts with the elevating the superficial layer of the deep cervical fascia over the sternocleidomastoid muscle. Elevating the superficial layer of the deep cervical fascia from the sternocleidomastoid muscle, we should ask our assistant to retract the fascia with the 2 or 3 muscies, and we should retract the SCM and separate it from the fascia from the sternocleidomastoid muscle. While doing this, there will be some perforating branches from the superior thyroid artery and occipital artery will be there that we should coagulate properly to reduce the bleeding there, and this releasing of this we should do till the posterior border of the sternocleidomastoid muscle. After doing this, the second step is to delineating the complete posterior belly of the digastric muscle. So this is a very important step here to identify the posterior belly of the digastric muscle in its complete length while doing level 2 resection. Because the posterior belly of the digastric is our important landmark here, and the major vessels will come deep to the posterior belly of the digastric muscle. After doing this, we should identify the spinal accessory nerve. As we can see here, this is the spinal accessory nerve. And now we can do neck dissection in two fashions. Either we can come from posterior to anterior, or we can come from anterior to posterior. Here I have done this from anterior to posterior part. So first thing what we will do here is to delineate the omohyoid muscle in its complete length till where it will cross the internal jugular vein. So fascia or the omohyoid muscle is lifted. There's a part of the superficial layer of the deep cervical fascia, and delineate the omohyoid muscle over the internal jugular vein. This is very important here, not to injure the interjugular vein, and this fibrofatty tissue present over the interjugular vein we should remove properly, because this fibrofatty tissue that is below the omohyoid muscle can harbor the lymph nodes. So after delineating it properly, the omohyoid muscle should be taken into the retractor. Now, after retracting the omohyoid muscle, the fascia over the interjugular vein, here we will identify the interjugular vein and ansa cervicalis. So it will be easy for us to identify our dissection area, plane of the dissection here. So we used to to identify our plane of dissection here only, then we will proceed from anterior part. So our plane of dissection in this area, in the area of over the carotid, will be over the vessels. It will be a supravascular plane that we will follow here. Ask your assistant to give a good counter traction while you are dissecting this dissecting fibrofatty tissue over the carotid sheath area. You should identify the superior thyroid artery here, not to injure the superior thyroid artery. There will be some perforating branches will be there, and they should be identified and clipped or ligate. In this area, we can use in initial part of the learning, we can use a musky and cold knife also for better feeling and better control. Now we will come to the area of the bifurcation of the carotid. Here, this is in the carotid triangle. You should be very careful because one can, if it is one is not very careful here, we can leave some fibrofatty tissue there, and there will be some veins from the pharyngeal veins will be there that should be clipped and ligated and expose the interjugular vein completely. Here in the level 2 area, what I am doing with the finger is I am palpating for the carotid knuckle, because in the older patients, carotid knuckle can be present in a level 2 area. So we should palpate for it, and we should do a blunt dissection with musky. After doing that, we should identify the spinal accessory nerve and where it crosses the interjugular vein. The spinal accessory nerve can cross the interjugular vein. Either most of the time it will cross above the interjugular vein, and but it can also cross below from below the interjugular vein, or it can two branches can be in between the interjugular vein also. So after dissecting the spinal accessory, we should dissect the level 2B area. 2B area, what we will do, we will identify the lateral border of the IJV, spinal accessory nerve, and C2. So we should not go medial to the C2, because our vessels will be medial to the C2 vertebra. After dissecting the level 2B and taking it from below the spinal accessory nerve, we should delineate our lateral border of the IJV. Here we should take care of our plane. Taking care of our plane is very important. We should stay above the prevertebral fascia. Then going to the level 4 dissection, we should be very careful while we are dissecting in level 4 area, because the three important structures are there in level 4 area. One is the phrenic nerve, that is there. Second is the transverse cervical artery, and third is the mostly on the left side, that is the chyle duct. So chyle duct can, the thoracic duct can come very high up in left side, and we should be very careful while doing this. Sometimes some anthropoid nodes can be there in the medial part of the level 4 area, and we should not try to chase all those anthropoid nodes there. And we should be very careful while dissecting level 4. We can use a bipolar cautery here for dissection in level 4 area. Then we should identify the transverse cervical artery. Here we can see the transverse cervical artery and phrenic nerve also we can see here. So here is the transverse cervical artery. This is the transverse cervical artery. This is the ascending branch of the transverse cervical artery. That we are here. I am using a bipolar cautery to. So this is the ascending branch of the transverse cervical artery. We should polarize it, or we can dissect it and ligate or clip it with the liga clips. The lower down we can see this. This is the phrenic nerve. So we should be very careful while using cautery there. I'm dissecting this ascending branch of the transverse cervical artery with a musky, and we'll clip it. After cutting the ascending branch of the transverse cervical artery, our specimen will be free from all the structures below, and we should keep on dissecting the specimen above the prevertebral fascia. In posterior part, we should take care not to go beyond the cervical rootlets, because and try to preserve the cervical rootlets. After doing all this, we should complete or remove our specimen being above the cervical rootlets and the prevertebral fascia. This is the part of level 2B that we have taken from below the spinal accessory nerve. Here in this area, one thing we should keep in mind that we should not chase the lymph nodes in this area where spinal accessory nerve is entering the sternocleidomastoid muscle, and cervical rootlets are going into the posterior triangle. Because if we'll go and chase these lymph nodes from here, we can injure the spinal accessory nerve from anteriorly. So this is the removal of specimen level 2, 3, and 4. After remove the specimen, this is our field of dissection. After level 2, 3, 4 dissection, our concern should go to the left posterior triangle to remove the level 5. Level 5 is bounded anteriorly by the posterior border of the sternocleidomastoid muscle, posteriorly by the anterior border of the trapezius muscle, and inferiorly by the clavicle. And it is divided into two parts by the horizontal line from the lower border of the cricoid, dividing it into the level 5A and 5B. First step in level 5 dissection is to identify the spinal accessory nerve where it exits the sternocleidomastoid muscle. The most important landmark for identification of the spinal accessory nerve in the posterior triangle is the Erb's point. Erb's point is the point where our retroauricular nerve exits the sternocleidomastoid muscle, and the spinal accessory nerve will be 1 centimeter posterior superior to Erb's point. So this is we have identified the spinal accessory nerve. We should carefully dissect over the spinal accessory nerve until it enters the anterior border of the trapezius lower down. Care should be taken not to use cautery around the spinal accessory nerve. Try to use bipolar or cold steel or stili to cut the fascia over it, and try not to lift the spinal accessory nerve from its bed to prevent the blood supply, and dissect all the fibrofatty tissue from level 5 above the spinal accessory nerve, below the spinal accessory nerve, and till low down till the transverse cervical artery. I'm using only the stele to resect all the fibrofatty tissue to prevent injury to the spinal accessory nerve. We can, after resecting in close proximity to the spinal accessory nerve, we can use cautery also. So this is our final resection. After the removal of the specimen, this is our final resection. This is the omohyoid muscle. This is the interjugular vein, carotid artery. This is the carotid artery. This is the phrenic nerve here. These are the cervical rootlets. This is the spinal accessory nerve here. This is sternocleidomastoid muscle posteriorly, and this is the anterior jugular vein here. So thank you, everyone. This was the steps of neck dissection. This is a comprehensive neck dissection from level 1 to 5. Any questions that we can discuss?
Ashok Das, Arjun, Burhan, over to all of you.
Yes.
Okay, let me set the ball rolling. Jitendra, very good presentation. Only one question. How do you preserve the marginal mandibular nerve? Because when we are dealing with early oral cancers, they have very long-term survival. And only thing they complained after 10 years is not the cancer surgery, but the deviation of the angle of mouth.
Yes, sir. We should actually try to preserve in the marginal mandibular nerve in all the cases where we are not raising the cheek flap and we are not removing the mandible, and we can preserve the marginal mandibular nerve clinically also. Sir, are you asking for the additive modalities we can use for preservation, like IONM?
Surgical techniques. I'm talking about the surgical technique.
Sir, surgical. Okay, the surgical technique is the most important thing. Is to identify the marginal mandibular nerve where it is exiting out from the anterior from the masseter. So while doing neck dissection, first step is to identify the angle of the mandible. The marginal mandibular nerve will most of the time it will present within 1 centimeter of the angle of mandible. We should identify it there, dissect it properly with using a cold steel and or a bipolar cautery above it. I will not prefer using the bipolar cautery also because it can transmit the heat while using a bipolar cautery also. So we should preserve it in.
So Jitendra, I just wanted to add, then Ashok Das can take over. When we are approaching the lower border of the mandible while doing the level 1, at that point, perhaps that is the only place using the knife is preferable. The reason is that the nerve is below the deep investing cervical layer. So once you cut it just over the facial artery and the vein, the neurovascular bundle, that is where you can see a shining transverse structure crossing over it. And yes, once you cut the deep investing layer of cervical fascia, it goes up. And that is where you start looking for marginal mandible now, first in the midline and then on the both sides. And once you have ligated the facial artery, just flip it over. And when you flip it over, automatically the marginal mandibular nerve gets saved along with the flipped vessel.
Yes, sir.
Ashok, over to you.
Sir, good evening. Jitendra, you have presented well. I have few small questions like, what is the anterior boundary of raising the flap in skin for skin flap raising? Because nowadays what happened, we try to do neck dissection in a single incision, and to go to level 4, we usually what we tend to do is that we raise the flap a little bit more on the anterior side. So what would be the limit of raising the skin flap anteriorly, anterior skin flap?
The anterior skin flap, because anteriorly or boundary of anterior level 2, 3, 4, anterior boundary of level 2, 3, 4 is the lateral border of the sternohyoid muscle. So we should not go medial to the sternohyoid muscle. There in anteriorly.
Exactly. So, yeah, that is absolutely not necessary. But even I have seen in your surgery also, sometimes we tend to do because, as I say, is many a times now we try to take out everything in a single incision, and in that process, sometimes we, for a little better access, we sometimes raise the skin flap little anteriorly.
Yes,
Okay.
sir. Yes,
So my second small question is that suppose suddenly you find a small, very suspected lymph node in level 1A. So, and you have sent it for frozen for your confirmation or this thing. So will, if that has come positive, if that come positive, will that change your surgical plan? Would you like to address the opposite upper neck?
Yes, sir. So if level 1A is positive, we should do a contralateral neck dissection because there will be higher chances of having a aberrant lymphatic drainage when there is a level 1A is involved in a primary that is very well lateralized. So there are various retrospective studies previously have been published that has shown that there are higher chances of involvement of the contralateral and neck is there when level 1A is positive in a well lateralized primary.
Thank you, Jitendra. Over to you, Dr. Arora.
Yeah, excellent presentation, Dr. Jitendra. I just have one comment and one question for you. It is a spinal accessory nerve. We are all able to preserve it physically, but it is very important to preserve the vascularity of the spinal accessory nerve rather than delineating it along its entire course. We need to maintain. We need not to actually change it entirely and maintain the vascularity of the spinal accessory nerve. Second question. The first question I have is, when do you address the buccal group of lymph nodes?
Pardon, sir?
Buccal nodes. When do you address the buccal group of lymph nodes?
Buccal group of lymph nodes we will address when there are periphyseal lymph nodes are involved. We suspect the positive periphyseal lymph nodes are there, and then in a buccal mucosa lesion or there will in those cases we will address the buccal group of lymph node actually.
There is a significant risk of around 3 to 6%, mainly in buccal cancers or the lower lip cancers or the cancer which are in the lower part of the nasal cavity. So these are the patients when you need to remove the buccal group of lymph node, when you get the facial artery and facial vein, and you can send it separately also. Dr. Pankaj, sir? Pankaj, sir?
Yeah, so you are right, absolutely right, Vipin. So whenever we are dealing with the cancer of the particularly buccal mucosa, gingivobuccal sulcus, then it is not that they directly come into the level 1. They trickle along the facial, and that is why whenever you are taking the facial stump at that time, I tell all the residents that you sweep all the tissue along the facial artery, even when you are not dealing with the cancer where you have visible metastasis or visible lymphadenopathy, because you may have a microscopic disease there.
Hi, Jitendra. Arjun here.
Good evening, sir.
Good evening. Very nice presentation and video. I just had a question, and I'm sure all of us have been in this situation. You know, you overzealously sometimes try to remove nodes from level 4, and you sometimes hit the chyle duct. So what would you do intraoperatively to sort of rectify this situation? And any post-operative precautions you would take?
Yes, sir. For while doing the level 4 lymph node, we sometimes what we do, we'll go on tracing the some lymph nodes in the medial to the IJV and injure the chyle duct. When the chyle duct is injured, and we in every case in our practice at Tata Hospital, in every case we while doing after the neck dissection, we do the Valsalva, ask the anesthetist to do the Valsalva maneuver to raise the intrathoracic pressure to see for any chyle leak is there. If the chyle leak is present, we should hold the area from where identify the area from where chyle leak is there, hold it with a vascular forceps and ligate it with surrounding some soft tissue there. We should ligate it because the chyle duct is very fragile. We cannot ligate it with singly. So we should take some soft tissue, whatever fat or soft tissue around it in the musky and ligate it properly. After ligating the chyle duct there, we'll use again give the Valsalva maneuver and check whether the chyle leak is still present or not. This is the intraoperative thing, and the postoperative period, when the chyle leak is there, we should keep the patient for fat-free diet for some time and see for the drain, whether it is a clear drain or chylous drain is there. If it is a clear drain, we will give the patient the fat challenge, and then we'll proceed and remove the drain. After giving fat challenge, and after 1 or 2 days, we'll remove the drains. And if the chyle leak is present post-operatively, we can, other than the fat-free diet, we can use the octreotide also. We have used in our setting, octreotide we have used in our setting. That is very helpful in a leak that is not settling with the fat-free diet.
So would you want to sort of divide this group as in a high volume leak or a low volume leak?
Yes, sir. It is the low volume, low output leak and high output leak. And there is a controversy over it whether when to call it a low volume leak or a high volume leak. But above 500 ml per day is we'll call it as a high output leak.
And if it's early, you would want to...
You have to do the re-exploration.
Correct.
Surgical re-exploration is required.
Good.
I just wish to add, Dr. Zinder, I just wish to add that when you are looking for a chyle leak and you have asked your anesthetist to raise the intrathoracic pressure, always look into the area at least for 30 seconds, at least, maybe more, because it takes some time for the pressure to be transmitted to in that area.
Yes.
So patience is the key over here. Look carefully into the area for at least half a minute.
Yes. Yes, sir.
I think it was a great discussion, and thank you, Pankaj sir, and thank you, Ashok sir, Vipin sir, Arjun sir, and everyone, Poonam ma'am, and all seniors. Jitendra, it was a very nice presentation, and the video was very nice. Also, it is important as everybody was pointing out regarding the nuances of preserving the thoracic duct, preventing thoracic duct injury, preventing the marginal mandibular nerve, the cervical rootlets, and doing the Suarez maneuver. And that is one thing which is forgotten. But I would like you to, everyone to pay attention to the spinal accessory nerve and avoid traction as well as thermal injury to the spinal accessory nerve. And as Sir Pankaj sir rightly said, that after good physiotherapy, almost after a year, even in a randomized setting, when they compared sentinel lymph node versus neck dissection, after 1 year, there were no differences in the shoulder function which was seen. So a good surgery can definitely prevent this morbidity. And I think over to the organizers for the next session. If anybody else wants to add anything.
I just want to add that
yes,
welcome Burhan to Tata
yes,
Hospital faculty list. Congratulations.
Thank you, sir. Thank you, sir. Thank you so much, sir. Thank you, sir. Sir, all because of your blessings.
Thank you, everyone.
Thank you very much, sir. Thank you, everyone.
Thank you.
So thank you, Jitendra, for this outstanding video demonstration, as well as the panel for their expert comments and the prompt response to the queries of the participants. We would now proceed to the next session, which is a panel discussion on reconstruction of oral defects with local flaps. The panel includes Dr. Sajid Babu. He is a senior consultant in Department of Head and Neck Oncosurgery, Aster Group of Hospitals, Kerala. Dr. Sean Joseph, he is director and consultant in the Department of Head and Neck Oncosurgery, Lakeshore Hospital, Kochi. Dr. Swagnik Chakrabarti, he is chairperson and consultant at Chandan Cancer Institute, Lucknow. Dr. Manish Maya, sir, he is consultant, head and neck surgery, University Hospital of Leicester, NHS Trust, the UK. And Dr. Devendra Gupta, he is professor, ENT and head and neck surgery, Army Hospital, RNR, Delhi. The presentation will be taken over by Dr. Poonam Joshi ma'am. She is professor, head and neck surgical oncology, Tata Memorial Hospital Center, Mumbai. I would request ma'am to kindly proceed with her presentation.
So a very good evening to everyone. I welcome all the panelists once again for this session. So this panel discussion is on the topic local flaps for oral cancer defects. So as we all know that oral cancers form the commonest cancer in India. Their resection leads to complex defects and significant changes in functional and aesthetic outcomes affect the quality of life of these patients. So the simplest method of reconstruction that achieves the highest level of function should be chosen. So if we see the history of flaps, it dates back to 1000 to 800 BC, that too from India by Shushruta, where he has described the nasolabial flap in his book Samahita. The first scientifically documented a human cadaver and as well as the dissection of the flaps was performed in Greece long time back, again to 150 BC. Again, then during Roman times, there was description of random circulation pedicle flaps. It was William Harvey who described the concept of arterial inflow and venous outflow. As we all know that it was Aryan in 1979 who revolutionized the head and neck reconstruction with the use of pectoralis major myocutaneous flap. This was soon followed by the introduction of free flap transfer, which has actually made the reconstructions aesthetically better and even functionally better. So as we know that free flaps are the most popular and versatile flaps for reconstruction of oral cavity defects. They can reconstruct small, medium, large defects. They can even reconstruct complex, challenging three-dimensional defects, and they are oncologically safe. Better donor morbidity as well as simultaneous rehabilitation can be achieved. So, but however, this panel, we will be only discussing the use of local flaps, and the discussion is for soft tissue defects and reconstruction. So moving ahead, I would just would like to discuss this point, Dr. Sajid, your point that on what factors your reconstructive decision-making will depend.
Yes, good evening all. The main factor is the defect, the size of the defect. So if, as you said, if it is only the soft tissue defect, we need only a soft tissue to be replaced. And if the size of the defect is not too large, most of the time a local flap would suffice. We don't need to overemphasize on a free flap in these kind of settings of small and medium-sized flaps. And of course, financial part also, financial and the resource factors also plays into according when we are making the decision.
So by saying the bony defect, we are not including, I would just like to clarify that I have not included the segmental defects, but we will be including where the marginal defects are there along with the soft tissue, because just for explanation. Yes, please go ahead, Doctor.
So that is what, so mainly based on the defect, for small, medium defect, we will consider flaps. And especially if it is not a salvage, if it is a de novo case, that a local flap will be possible. But if it is a revision surgery or a post-radiation surgery, a local flap may not be considered in those settings.
Correct. So, Dr. Sean, would you like to add something?
Yeah, Poonam. One thing I would add to add is the site of the defect also makes a difference to me in my practice, because if it's a floor of mouth reconstruction, I would see like whether to include irrespective of other factors, whether we should include a free flap or whether we should use a local flap. An issue with like a site like the floor of mouth or the undersurface of tongue. The issue what we find is if we use a fasciocutaneous flap, whether it be free flap or any other fasciocutaneous flap, the tongue gets tethered down and the mobility of the tongue gets affected badly. So we have been facing this issue, and this has come down really, it has improved after using mucosaline flap for floor of mouth or undersurface of tongue reconstruction. So that's something which I would consider, because a floor of mouth or undersurface of tongue, I would think a local flap, like a islanded facial myomictomy, superior to a facial flap. But when it comes to an actual defect, it may not make a difference, and you may, in certain cases, you may switch, like you may consider free flap to be superior also. But for a floor of mouth, undersurface of tongue, and another site which I would say is like a palatal defect. A limited palatal defect, you can use a free flap as well, but islanded facial artery, I mean, it's like when you move it like a propeller type flap, in a propeller like way, you don't need to island it. You can just mobilize it towards the palate and cover it in a very simple and easy way, and you will have a like for like appearance in the palatal area. So these two areas, I would prefer a local flap to a fasciocutaneous flap. But on the other sides, the size of the defect is large. A fasciocutaneous flap would be better in many situations. In some situations, it may be equivalent to a local flap. And one more issue which I would consider is the situation, the patient condition, whether the patient has comorbidities, whether the patient is high risk for surgery, and whether the patient is a post-radiation, post-surgery, like post-surgery, post-radiation recurrent patient. All these may affect my treatment decision making.
Correct. Thank you. So there are several factors which influence the reconstructive decision making. Few of them we already discussed, like the patient factors. This includes the patient lifestyle and expectations naturally, the medical conditions, the major cardiac morbidity or the renal morbidity, where long surgery may not be feasible, then donor site scar and morbidity, that where is the location of the donor site, the hospital factors like universal healthcare systems where there are long waiting lists, the availability of intensive care unit, if it is available or not, microsurgical instruments, paramedical facilities for appropriate rehabilitation, and obviously the surgeon factors. So, Dr. Swagnik, what criteria do you use to classify the defects? Like we just heard that the size of the defect is one of the criteria. So, like, how do you decide like, oh, this is the kind of defect, and I will be doing this kind of local flap for this?
Local flaps are ideal for small oral cancer defects, early cancers with no nodal metastasis, and with no segmental mandibulectomy defect, no bony defects. So T1, T2 cancers, buccal mucosa or tongue or even the palate can be well reconstructed with a local flap. But one thing I would like to stress here is that especially for buccal defects, preferably it is always preferred to put in a vascularized epithelial flaps vis-a-vis split thickness skin grafting, which causes significant trismus in the post-operative period.
What are your thoughts, Dr. Manish?
Hi.
Hi.
So I think in terms of classification, there are certain classification given by few centers like Kochi, and there's also an Italian classification for tongue. And obviously, you're showing the maxillary defect classification, which is given by Liverpool by James Brown, which is quite famous. It does tell you about the different types of flaps to be used for maxillary defect, but mainly they talk about the free flap reconstruction in maxillary defect in Liverpool. But I think with the Kochi one, I think class 1 defect, class 2 defect can be considered either by primary closure or keeping it raw, or a local flap, while class 3, class 4 would benefit more with a fasciocutaneous free flap.
Correct. So I think there are a lot of classification systems. This is the previous one by the Amrita group, which already Dr. Manish has described. Then there's another classification by Liu et al. And then they have included several kind of like vertical and the horizontal defects. But again, this is a bit cumbersome and difficult to remember. But in fact, they have included different kind of defects together. And then there is a simple classification, which I felt was much more easier and appropriate in most of our cases, which is the Square R et al., where they have described the defects as small when the defect size is up to 4 centimeter maximum diameter. Medium, they called it if the size of the defect maximum diameter is up to 7 centimeter, and large if more than 7 centimeter. So various defect characteristics we already discussed, like the size of the defect, the subsite involvement, the different tissues involved, either whether the mucosa is involved, skin is involved, bone is involved, is going to affect the type of reconstruction. Then the functional dynamics, like we saw, if it is involving the floor of mouth, it is involving the tongue, or it is involving the buccal mucosa, is going to make difference, which we'll be discussing further. Then prosthetic rehabilitation is, if possible, for the defect is also important point to be considered. So,
Poonam,
yeah.
Before we go further, we have to give the message that when we mean local flap, these are the flaps which are taken in and around the neck as well. So many times the message is given that local flaps means whatever is taken from the oral cavity itself. So here we are talking about those flaps which are taken from the neck as well. Okay, correct.
Correct. So, so Dr. Devendra Gupta, do you reconstruct every defect? So, does every defect need reconstruction? So, what is your take on that?
So, you already described that the various defect size, classification based on the size as well as the site. Hello, am I audible?
Yes, we can hear you, Dr. Devendra.
Yeah, so the small defects, especially in the tongue, we can get away without doing a reconstruction. But if it is a buccal mucosa, then as Dr. Swagnik already told that we should use an epithelialized, vascularized epithelial flap. So the size and the site would be the main criteria. We can get away without doing a reconstruction in maybe small tongue defects, T1 lesions.
Correct. So the aim of reconstruction is to restore oral competence. We know adequate mouth opening, mobility of tongue should be restored, speech and swelling to be restored to the maximum extent, and the separation of oral cavity from nose, nasal sinus, and the neck. So whatever kind of reconstruction if it can achieve, we can go ahead and do that. So there is a newer concept right now, is that of reconstruction elevator. Earlier we used to read about the reconstruction ladder, but now they have converted it into elevator, where the concept is that the most important, the most appropriate flap needs to be selected, whether it is the least complex type, which is we see the arrow which is going down, where it is a primary closure, or it is healing by contracture, or it is a negative pressure therapy, or it is a skin graft. Whereas the upper arrow shows more complex kind of reconstructions like regional flap, local flap, and free flaps. So whatever flap is appropriate for a defect, which can reconstruct and can provide the aims of reconstruction, can be used for the same. So like we just saw that the small defects, which are usually less than 4 centimeter, if we take it for ease of understanding, they usually can be managed with the help of primary closure, but then it should be a tension-free closure. Then secondary intention healing is also one of the options, but one need to be careful that with all these options, there is always a chance of decreased mouth opening, and that needs to be taken into consideration. Then skin grafting is one of the options which we all have used, and naturally local flaps, which we are going to discuss it further. So like Dr. Sajid already described, what are local flaps? Local flaps are situated in proximity to the resected area. They provide the same type of tissue. The color and texture matching is similar, and they do not require specific microsurgical instruments. But they have naturally a lot of limitations. They have limited arc of rotation, limited availability of tissues, and they do not provide bulk. Moreover, presence of nodal disease may interfere in some cases. So I have put few of the local flaps here. This list is not exhaustive, and I have included most of them which we use at our institute. So some of them include the buccal pad of fat we all have been using for years, tongue flap, palatal flap, nasolabial, malolabial flap, both pedicle islanded, fan flap, infrahead, submental flap, supraclavicular, and platysma myocutaneous flaps. So again, Dr. Sean, what kind of defects? I think this we have already discussed, the defect that you already said, small defects, medium-sized defects. Most of the time they can be reconstructed with local flaps. Floor of mouth defects, like you rightly said, along with the tongue can be reconstructed with. Usually the large defects are not suitable to be covered with the local flaps. So here we'll not be discussing exclusive lip or cutaneous defects. So for defect A and defect B, Dr. Sean, what local flap will you be using? So one, defect A includes only the palatal defect, while the defect B includes the part of alveolus also.
See, in this defect A, if we can mobilize the palate, the palatal flap and close it, that will be better. Like you don't have to disturb the buccal mucosa at all. For the second defect, you have a larger defect, and it's with the loss of tooth as well. So in the second defect, I would consider using a facial artery myomucosal flap. And while suturing, I'll just make sure that the tension at the palatal flap to the FAM interface is tension free. Like you can distribute the tension in such a way that a little away from the center towards the periphery, there can be a little bit of tension, but at the center, you don't have much tension because the sutures may give way. So that would be my consideration.
I think some of the defects which we have used in our reconstructive measures is palatal flap, buccal pad of fat. I think we all use, but usually that will not reach that area for this thing. I think I have written that. Nasolabial or malolabial flap, submental flaps we have used, and the tongue flap we have used for the reconstruction. We'll come to each and every case where it is good or not. That we'll be discussing. Yes, Dr. Sajid, you would like to add something?
As Sean said, the first one, if possible, palatal rotation flap is a good option. Otherwise, radial forum fares well in these kind of defects usually, because even when we rotate the palatal flap, the edge seems to be a problem. Sometimes a small defect in this, because if you are taking the, I hope this is a bone defect. There is a bone defect as well in this kind of.
Yes. We have included the bone defect as well.
So even a small defect which is remaining will cause a trouble to the patient. So we have to be careful in these kind of scenarios. The second patient, if it is a female, my choice would be a submental flap. Tongue flap, etc., is little cumbersome to manage because we have to put the tongue to the palate, and then it is little difficult to manage. Nasolabial, in small defect, more lateralized. If it is not more towards the midline, this can be used. Another one is the temporalis muscle flap, which can be used again in these kind of scenarios.
Correct. Dr. Manish, you want to say something?
Yeah, so I think local flap is important, obviously, in this case, but I need to emphasize the point that obturator can be a very good option in this situation. It will really help in early rehabilitation, easy for postoperative monitoring of the disease. Palatal flap, I still feel will be difficult in the first defect as well, after getting all the margins and rotating the mucosa. But yeah, obturator I think would be my first choice actually in these cases.
Correct. So I think we all agree to that most of these defects, I think a larger flap, palatal flap can be option, Dr. Sean said. But again, for the second defect, obviously it is not. And we need a bit larger volume of the flap to cover the defect. So this is the kind of buccal mucosa defect, defect A, defect B, where defect A is mainly the buccal mucosa defect, and defect B is the defect for which involve the marginal mandibulectomy.
You are
and
not
upper
audible, ma'am.
Hello? Hello?
Yeah, we can hear it. We can hear it.
Sorry.
Yeah, now you are audible.
Yeah. So the defect A is mainly the buccal mucosa defect, and defect B is the defect where there is marginal also will go along with the
You
upper
are not
elbow.
audible, ma'am.
Am I not audible?
Yes, now you are audible. So
Yes. Yes, Swagnik, you can go ahead and tell me.
Yeah.
How will you reconstruct if we have local flaps only?
Yeah, for this patient, this is a buccal mucosal defect. Now, going through a list of flaps for local reconstruction, if it's a buccal, it's a pure buccal mucosal defect. Hello? Can you hear
Yes,
me?
we can hear you.
Yeah,
We can hear.
And if a submental flap reconstruction is a good option for this patient. Again, as I emphasize, I will avoid putting in a skin graft. Other options being a tongue flap, or even maybe a palatal rotation flap based on the greater palatine artery. But preferably, we are talking of local flaps, I would prefer for a submental flap, but I'll be very careful selecting the patient, as these diseases have a high chance of nodal metastasis to level 1B and 1A.
Correct. So I agree with Dr. Swag. Yes,
Before
please
that,
go ahead.
in all cases where we plan a local flap, we should have a plan A as well as a plan B. Because only when you go in, most of the time you realize that the defect is much larger than you have expected. Sometimes you, if you send frozen, your margin may be closed and you may have to excise a little more. And there are situations in which you might see in a better light settings, you will see a little bit of leukoplakia or premalignant lesions in the surrounding mucosa. So your resection may go a little wider. So always have plan A as well as plan B. Like in if it is in the first case, I think a buccal fat pad would be a good option. But sometimes as you go in, if it is a little larger, it will not cover with buccal fat pad. Always you should get consent for the nasolabial flap as well, because nasolabial will fit in very nicely in this patient. Second defect, yes, submental flap is a good option if it is a female patient, or if it is a male patient, my choice would be a supraclavicular flap.
Correct. So now these are some of the flaps I have described, which we have used, or I took it from the literature also. In a way, I agree with Dr. Swagnik that usually we also don't use submental flap for the buccal mucosa defects, because the chances of nodal metastasis to level 1B is a bit higher, and we usually prefer it for varicose. But then that can be a point which can be discussed further also. So, so these are the floor of mouth defects. Again, this,
can I have a point? One important point in the previous case is that these, when you resect such a lesion, your base is formed by the buccinator muscle. And if you see the anatomy, the facial artery mostly will be resected in the resection. So the defect will only leave behind skin and subcutaneous fat. So using a nasolabial flap for this case will be, I think, for pure buccal lesions, a nasolabial flap is not a great option.
Correct. Dr. Manish?
Yeah, I was just on Swagnik's point, I would suggest that a reverse nasolabial flap would work in this scenario. They work really well with good mobilization and primary closure in that area.
Correct. So even a reverse flap can be used for that situation. But I think that's a point which can be debated further, which Dr. Swagnik also said. So I think again, the floor of mouth defects, the defect A is unilateral, B is involving a bit more larger, and C is involving whole of the floor of mouth. So Dr. Sean, your point, how will you reconstruct?
In any of these patients, in all three patients, if the patient does not have any trismus, I would consider an islanded facial artery myomucosal flap, because I've tried other flaps. I've started doing with the faciocutaneous free flap, but the issue is the tongue movement gets affected badly. with the islanded facial artery myomucosal flap, I found that there is a definite functional advantage. That's why I was trying to share that video with you so that people would understand. So in this particular situation, islanded FAM would be my choice if the patient does not have any trismus in any of these.
Dr. Devendra, your inputs?
I agree with Dr. Sean. However, we can use an islanded nasolabial flap also in such situation.
Dr. Swagnik?
Yeah, Dr. Sean is a master of this FAM flap and Devendra is a master of islanded nasolabial. So I will go with both of them.
Will anyone of you consider infrared flap?
Yes,
Dr. Sajid?
Yes. Infrared flap is a very good option, in especially in the third condition, that is C, because the defect it is not only in 2 dimensions. The third dimension also, it will be a large defect because it seems to be a probably an infiltrating kind of lesions wherein we will have a defect like this. In those kind of situations where we need a bulky tissue to cover the floor of the area, the infrared flap fares very well. So in C type of defect, and also in B, we can infrared will fit in very nicely. Submental flap, if it is N0, of course, we can consider that in a female patient. And my point against Sean's islanded FAM flap is that whenever we island it, both in islanded FAM as well as in nasolabial flap, the marginal mandibular nerve gets damaged. That is only the worry which I have, because I have also used it initially, but that is a problem. That has been a problem always. And so that to avoid that, the other flaps would be a better choice.
So we have also in our practice used all these 3 flaps for reconstruction, and naturally each one has its own limitation and advantages. I think we'll be coming again for that. So these are the tongue defects, again tongue defect A and B and C. So what is your take? Anyone can take this thing. How will you reconstruct these? Do you think there is a possibility for local flap for reconstructing these kind of tongue defects? Anyone of you?
Yeah, Poonam, can I?
Yes, Dr. Shah.
If it's an anterior tongue, tip of tongue defect, anterior 1/3, if we do not reconstruct, the tongue gets an unusual appearance. And another thing is like certain voice, certain sounds can get affected, like the post-dental sounds and all get affected. So in the anterior 1/3 defect, where the free unattached portion is affected, so I would prefer to do a tongue advancement so that the unattached tongue portion remains in a working condition, and the defect is somewhat transferred posteriorly. So I would like for an anterior 1/3 defect, that would be my choice. For a larger defect, like which is involving the anterior portion of the tongue, I'd be very concerned, because any of the flaps, if we put in the front portion of the tongue, the issue would be the tongue mobility gets affected. So if it's not affecting the floor of mouth, if it's just the anterior 1/3, anterior 2/3 of the tongue, the whole of it, if it's going, if you consider putting in any flap in that position, the tongue mobility actually can get affected. That's what I felt, because the free movement of the tongue, the native tongue mobility can be affected because of the flap bulk. So for the lateral defect, like the A defect, so for this any fasciocutaneous flap should do very well. So that's what I would think. Like, I would like to get the other opinion.
Yeah, Dr. Swagnik.
Ma'am, for the first defect A, if a local flap is to be done, I would prefer a islanded nasolabial flap. The reason being so, for islanded nasolabial flap, we don't need to have a classical N0 neck. Even it can be done an N+ neck as well. Second thing is that the advantage of islanding is that we are having a large arc of rotation, and it behaves almost like a free flap will attaching to the tongue. So the restriction of the tongue mobility is not there in an islanded for vis-a-vis if we use the random pattern flap or any other local flap. Second and third defects, I would opt for a microvascular reconstruction.
You will opt for a free flap.
Free flap, yeah.
Okay, okay.
Not.
Anything else, Dr. Sajid, Dr. Devin, Dr. Manish, you would like to add?
If we have decided on doing a local flap, all these three defects can be covered with a local flap. We have various options like the nasolabial flap. It has to be islanded if you are using it for the tongue. Both in the I think first two A and B we can use a nasolabial flap, whereas B and C it would be better to use an infrared flap because it would give a good bulk. Always we have to be little we have to plan our flap and also have the backup if it is not reaching well, because the infrared flap sometimes we may get stuck by the reach of the flap.
Correct. So in our experience also, hello, yes, anybody would like to add? So in our experience also, we have our own data, which like in the type A and type B, we have been able to reconstruct majority of our defects with the help of islanded malolabial flaps. But the defect C is difficult, and it would be preferable if we could reconstruct it with some other flap, preferably a free flap. So we know that tongue defects, they can be closed primarily, but none of this defect was ideal. Local flaps, again, for tub defects we discussed, can be islanded malolabial flap, then FAM flap, infrared flap, and submental flap. These are some of the options. I will not be going into details. This is the study by McConnell. We know that the defect size up to less than 1/3 or 30% can be closed primarily. But there are data where they have which has shown that even tongue which is kept raw or covered with skin graft gives better mobility or swallowing. So there are contradictory. This data, few patients, 104 patients which we collected prospectively, and we have seen majority of our defects which were type A, type B, and we were able to reconstruct them with islanded malolabial, FAM flap or infrared flap. And FOM, again, we discussed with the similar buccal mucosa, marginal or upper alveolectomy defects, we use supraclavicular or platysma myocutaneous flaps. Buccal mucosa lip defects, we have used submental flaps. In our data, we saw that malolabial was the most robust flap. We did not see out of 63 a single loss of flap in these patients, because naturally if the facial artery is there, vein is intact, it is a very robust flap. However, there were few donor site morbidities. Then again, the supraclavicular flap, we had a lot of failures, not complete failures, most of them were partial failures, and there were donor site morbidities also. So this is just our experience, not many cases, but this is few of the cases we did at our institute, which we collected prospectively. So again, this is, we know just for once again we are discussing. So buccal pad of fat, would you use it regularly, or like Dr. Sajid, what's your take on it? We'll just remaining 10 minutes.
Any small defect, especially for T1 and T2 buccal mucosa, buccal fat pad is a first choice, because it is very readily available. You don't need to disrupt any other area, and it heals beautifully within a week's time. But the one point for caution is that there may be a trismus. So if the patient is already having submucous fibrosis on the other side, better do not use this flap, because this buccal fat pad also will cause some amount of trismus. And second, thin patient with a hollow cheek, you may not get much of buccal fat pad. Again, you may have to plan another flap like the nasolabial. Sometimes these kind of buccal mucosa defects, though nasolabial is a very good option, sometimes what happens, the depth margin may not be adequate, and you may have to go in or do a deeper resection, and the facial artery will come along with it, and your nasolabial will not be possible in such situations. So always plan another flap in these kind of scenarios.
So buccal pad of fat usually for very small defects up to 4 centimeter, which the literature suggests in our experience also. And most of the time there should be no OSMF, and mouth restriction, the restricted mouth opening, like Dr. Sajid suggested, has to be taken care of. Then palatal flap, again, Dr. Son, your point for palatal flaps, when will you do?
Yeah, palatal flap, small palatal defects, even if it is involving the bone. palatal bone, we can reconstruct with the palatal flap, or a larger palatal defect, including the bone, including the palatal bone, you can reconstruct with the facial artery myomucosal flap, which is completely islanded but not taken down to the neck. When it is moved like in a propeller-like fashion, it can easily cover most of the palatal defects in a very simple and easy way. So that's why I was telling. Initially, I was using radial artery forearm flap for these defects, but after switching to FAM for palatal defects, I felt that it is simpler, easier, and gives some mucosal appearance to these defects.
So palatal defects, flaps, again, they are ideal for small defects on the palate, maxilla, or retromolar trigone, and they can be used for these situations. Tongue flap, anybody who has experience with the tongue flap, who does tongue flap? Dr. Devendra, Dr. Manish?
I have used it for other situations like the alveolar defects or the gingival defects, because the tongue, it usually sits, the transfer is very easy, it sits. And very occasionally for the lip reconstruction. These are all difficult to place, and for especially for the posterior defects. If it is anterior, that pull always creates a trouble.
Correct. Dr. Devendra?
Well, for tongue flap, I do not have much experience, but rather than taking a posteriorly based tongue flap, what I do is I do a hyoglossus release and then surface the buccal mucosa with the undersurface of the tongue, which comes over the undersurface of tongue, especially for the small posterior defect of the buccal mucosa retromolar trigone.
Okay. Dr. Manish, what is your suggestion?
I agree. Yeah, sorry. I agree with Dr. Devendra. If the buccal mucosa defect is significant, hyoglossus release would definitely benefit. The only thing I think tongue flap might be useful is in some small palatal defect or RMT defect, where you can switch it. I can switch the mucosa in that region, but obviously it comes with the morbidity of the procedure, as well as it's a two-stage procedure where it needs division. So we have to take into that while planning.
Yes, I agree, because tongue flap has its own morbidity, especially a tongue, which is a mobile and functional organ. And usually we also prefer it to be used as the last resort. So we'll be using other kind of local flaps before using a tongue flap. So infrahead flap, once again, anybody would like to comment on this? So in our practice, it is a wonderful flap. We usually use it for the floor of mouth defects and for tongue defects also, but we have seen that usually the limitation is the reach of the flap, because it depends upon the location of the superior thyroid pedicle. And usually the failure rates are not very high. Superficial skin loss we had encountered in 1 or 2 cases. However, it is not a very difficult flap also to learn, but a level 3 note is a contraindication. So Dr. Sajid, any point you would like to add?
Yeah, 2 points. Sometimes we may end up with this venous congestion of the flap because of the pull and traction. But many a times these are all superficial. The skin sometimes gets peeled off, whereas the muscle, the robust muscle stays, and then that heals secondarily. That heals without any issue. So many of the time, if you see, there will not be total flap loss, only a partial loss that usually happens. Second point is that in some of the situations, after you raise the whole thing, only you may come to know that there is a reach issue because of the vein, because the reach is mainly because of the vein which is draining it. So in those conditions, what we can do is we can cut the vein and anastomose it to the facial vein and then surpass the problem. Like
better you do a radial
single anastomosis to the vein.
Then it becomes a free flap.
Becomes a free local
free
flap.
infrared flap.
Free infrared flap. Free and local both. So then this is one of the flap, which is platysma myocutaneous flap. We have experience of 4 or 5 cases only, but we felt it is a good flap. In fact, this usually is ideal for a small to medium-sized defect, buccal mucosa defect. We can cover the buccal mucosa, marginal mandibulectomy, and upper alveolectomy type of defects with the help of this. But again, the venous blood supply is unreliable, and usually you can sometimes have the venous congestion of the skin flap, and the skin loss can be there. This patient, in fact, I had the skin loss, which I have shown here. but the neck morbidity is not there at all, and it closes in the same transverse neck crease of the neck dissection. Any experience anyone would like to add to that? Anyone?
Not used it.
Yeah, it's a very limited experience. Oh, sorry.
Yes,
sternum-mastoid flap. Again, it looks initially looked like a sternum-mastoid flap, but the sternum-mastoid flap also has the same scenario, but again, not a reliable one.
Yes. So I think there is another submental flap. I think we all have done it, and it is a very good and robust flap in our series also, in our experience also. The failure rates are minimal if you trace the submental vessel properly. However, nodal metastasis to the oral cavity from the oral cavity is a question. And in our institute, usually we prefer to do it for the verrucous lesions or like where we don't have a positive biopsy. Maximum we have to do well-differentiated SCCs, but we don't prefer it to do for the moderately differentiated cases. Anybody would like to comment upon the submental flap, the advantages and the limitations?
That's an excellent flap, submental flap. We have used quite a number of situations. 2-3 important points to be preferably avoided in males because of a beard issue, if possible. Second point is that the flap, the patient selection is important with very thin built patients with minimal subcutaneous fat. Again, the flap is an issue. Otherwise, a very, very robust flap and reliable. Again, taking into consideration buccal mucus, as ma'am rightly said, we only consider it for verrucous lesions of the oral cavity where there are chances of neck nodal metastasis are minimal, and to be preferably avoided in a tongue cancer patient where the flap just lies below the mylohyoid separates the tongue from the flap. So yes, verrucous lesions, small defects, female patients, good flap.
Yeah, I completely.
Can you show the previous slide?
Yeah, sure.
See here, the flap has been drawn as or taken as a horizontal flap. Okay, in these kind of scenarios, the nodal dissection will be a little issue. But if you are using it for a smaller defect, we can take the flap as a vertical flap, that is from the mental area to the hyoid, and then the thickness, the width would be around 2 to 3 centimeters, especially for those smaller or a medium-sized defect of the tongue. So in those scenarios, the flap lies directly over the digastric muscle, and you can do level 1A dissection on the lateral side, and also complete the and do the complete level 1B dissection medial to the flap. Sorry, the other way, the lateral to the flap and the medial to the flap level 1A. So that way we can do a neck dissection. So in those conditions, it is completely oncologically safe. There we do the neck dissection in a proper way only.
So you mean to say that the flap is based basically on the anterior belly of the digastric?
Basically on the anterior belly of digastric. So onto one side of that, we can even completely
do the 1A clearance also.
Yeah.
Correct.
Correct. So I think the only one point I would like to add is that usually when we do at our institute the submental flap, we include the anterior belly of digastric along with the part of mylohyoid muscle, and because the vessel is usually sandwiched between the two. So that is the area where the dissection is difficult because the vessel becomes very thin. And the other point is that if you have to be meticulous and dissect the vessel there between the anterior belly and the mylohyoid muscle, and there can be nodes also. So their area you have to be particularly careful when you are dissecting that area. So that's the point I would like to make. So we have already discussed submental flap is easy to harvest, pliable. Large flap can be raised from one angle of mandible to the another, or it can be made smaller also as per the need. We prefer it for verrucous lesions, and we have used for different defects. Tongue carcinoma, we are not very sure because like Dr. Swadnik said, if it is, we have to remove mylohyoid as a margin, then this will not be appropriate. So this is another flap, which is the supraclavicular flap. Again, it is a good flap. However, again, our experience with supraclavicular flap was not that great. We had a lot of morbidity, especially the partial losses of the flap, but it is a good flap if we can reconstruct it. If it survives, the venous blood supply is an issue. So anybody would like to share their experience with this? Because we are only left with 2-3 more minutes and we'll be rushing it to that.
An excellent flap for buccal carcinoma, wherein T2 or T3 buccal carcinoma, wherein you remove the entire buccal mucosa from commissure to the RMT and from upper GB sulcus to lower GB sulcus, or even along with the bite resection. In those kind of defects, as it is, I think this case which you have shown is a bite resection. This flap is a very good option. It is, the final result is almost similar to the radial forearm that you would place. The reach should be checked prior to the surgery, because some patients may have long neck and a short shoulder. In those patients, it will be little difficult. In otherwise, it's an excellent flap for those conditions.
Yes, thank you.
The deepitheliation has to be done very, very carefully, because deepitheliation should not damage the subcutaneous blood supply. That's the reason. And while inserting the flap, the distal edge, the bleeding of the distal edge needs to be checked very clearly, and there should be pretty good arterial bleeding from the distal edge. Otherwise, the distal edge is prone to necrosis.
Yes, I completely agree.
Another point is that the person who is doing the flap should do level 4 and level 5 dissection. Like he should not, the resident should not be doing the neck dissection and the consultant comes later or to do the flap. That will create a trouble.
Yeah, because by that time the vessel will be gone. So we did a few cases of even bipedal supraclav flap, and in fact they survived. So I just put the photograph that it can be used for them also sometimes, but again it is a bit unpredictable, at least in my experience. There can be shoulder morbidity sometimes if the defect size is more than 7 centimeter. You have to,
important.
yeah. So there you can put a skin graft. Otherwise, it can be closed primarily. So width of the flap is also important to be taken into consideration. Then islanded facial artery myomucosa flap. I think this better photographs. This were shared by Sean with me, and this have been used by for heart pellet. And the other one is a nice video, which is, so we can see this FAM flap has been used here. So wonderful tongue mobility. It has healed very well. Yes, Dr. Sean, would you like to add something?
I think I've already told about this. Yeah. So this is the reason why I prefer islanded fan for floor of mouth, because it definitely has a functional advantage. So that's just the point. I mean, I just wanted to show this video just so that people understand, because I found it difficult to get that mobility with any fasciocutaneous free flap or any fasciocutaneous flap. So that's why I wanted to show that.
Yeah, sure. So I think the last and I think the most commonly used by, at least by us, islanded malolabral flap. Swagnik, your word on this?
Yeah, ma'am. We have been doing it for, I mean, previously quite a lot of cases, and me and Devendra published it in Laryngoscope. So this is a good flap. The points here is that the first thing, it's to be avoided in pure buccal mucosal defects. The width of the flap is important, because you take a too wide flap, then it causes a very bad functional outcome, functional and cosmetic outcome. So width should be preferably between 2.5 to 3 centimeter, not more than 3 centimeter. And the flap is a large arc.
Flap discuss kar raha hai.
It's a large arc of rotation and can be used for the reconstruction of the opposite side also.
Yes. So I think islanded, we are already ahead of our time. So just to this thing, the take-home message, the appropriate choice of deconstruction depends upon the defect and patient characteristics. Local flaps can be used in certain situations as discussed. Learning curve for local flap is not very steep. Well versed with vascular anatomy of the face and neck is very important. And assessment of defect and meticulous planning is important for planning of the flap. Primarily, closure of the donor site is preferable, and donor site morbidity should be minimal. And zero status of neck is preferable, and oncological safety is foremost in selection of these flaps. With this, I thank you all because we are already ahead of our time. And I thank you, everyone, Dr. Sajid, Dr. Sean, Dr. Swagnik, Dr. Devendra, and Dr. Manish for their contribution to this panel and telling us the various options and the limitations of these flaps. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Thank you.
Thank you.
Thank you, ma'am, for this wonderful presentation and the expert panel for their valuable inputs. This was indeed a detailed presentation that covered a amount of local flaps and has given us a better insight. Moving on to the final session for day one is the operative technique on PMMC flap. The expert panel are Dr. Anuja Deshmukh, ma'am. She is professor in Department of Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. Dr. Deepak Balsubramaniam, he is professor in the Department of Head and Neck Surgical Oncology, Amrita Institute of Medical Sciences, Kerala. Dr. Ratan Shetty, sir, he is associate professor in the Department of Head and Neck Surgical Oncology, Tata Memorial Center, ACTRAC. And Dr. Mayur Mantri, sir, he is associate professor in the Department of Plastic and Reconstructive Surgery, Tata Memorial Hospital, Mumbai. The speaker for this session is Dr. Shivkumar Tyagarajan, sir. He is professor, Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. Sir, I would kindly like you to share your screen, please.
Okay, should I go ahead with sharing the screen?
Yes, sir, please.
Okay, I'll do that. Is my screen visible?
Yes, sir.
Should I proceed or?
Yes, sir, please go ahead. Thank you.
Okay, so first of all, I'd like to thank the organizers for this opportunity. So I've been asked to talk about the operative technique of pectoralis major myocutaneous flap. I think one of the first flaps that I learned to raise and also one of my favorite flaps to do till date. So just before we proceed into the techniques, I thought it's important to know a few aspects about the historical facts and about a few applied anatomical aspects. So PMMC flap was originally developed in the 1940s for reconstruction of the cardiothoracic defects. And though it is commonly attributed to Stephen Aryan based on his paper, which was published in 1979 in the Journal of Plastic Reconstructive Surgery, it was Brown and Fleming in 1977, and subsequently Maruyama from Japan in 1978 would actually publish their work. And then subsequently the paper that actually took the limelight was the one published by Stephen Aryan. So later on, Stephen Aryan and Kuano further utilized the costochondral segment with the PMMC flap for mandibular segment reconstruction. And subsequently, many variants from this flap, like the pectoralis major myofascial flap, only the muzzle without the skin paddle was developed. Later on, the bipaddle PMMC flap was developed, and certain female-friendly versions like the inframammary paddle and the crescentic skin paddle medial to the nipple areolar complex was also reported. So there are various modifications other than these, but then these were the initial, report of the pectoralis major flap and some of the modifications and techniques to it. So what is the advantage of PMMC flap is that it's an easily accessible flap, which is closer to the surgical field. It's technically simple to harvest. There's a very reliable anatomy, robust and reliable vascular anatomy that is always there, very few variations that you would encounter, and minimal requirement for specialized instruments and training. So these aspects makes the PMMC flap, being done routinely, and it forms the workhorse of the reconstruction in many of the centers even till date. So it's very important to know the anatomy of the pectoralis major myocutaneous flap. So it's a thick fan-shaped muzzle that abducts and internally rotates the humerus. The blood supply comes from the pectoral branch of the thoracoacromial artery, which is from the second part of the axillary artery. Based on the classification of the flaps, it's given by Mates and Nahi. It is a type 5 muzzle, which has one dominant pedicle with multiple other contributors. And it drains via the vena comitans, which accompanies the artery, and into the axillary vein. So you have the clavicular and the sternal head, It arises from the medial aspect of the clavicle and also all along the sternum, and then especially the lower of the part of the ribs, and then it goes on to attach to the humerus. So the most important point that we need to understand is the vascular anatomy as it goes, to understand how we can place the skin paddle to raise the flap. So we know the blood supply that comes from the thoracoacromial artery, and that is the dominant pedicle. You have the perforators coming from the internal mammary artery, especially from the first, second, third, and fourth, intercostal space. And you have a few vessels coming from the lateral thoracic artery as well, thoracoacromial artery, sorry. So, and a few vessels coming from the superior epigastric artery. So these are all the minor contributors. Now, as the thoracoacromial artery comes down along the vessel, the upper part of the muzzle does not actually have any perforators coming onto the skin paddle. In fact, the amount of perforators are fewer compared to the perforators that you would find in the lower part of the skin, as you can see here, in the diagram. So what happens here is, at this level, there are multiple choke vessels. What are choke vessels? Choke vessels are vessels that connect to angiosomes. That is, two zones where the blood supply is coming from two different arteries. So these choke vessels actually, mainly, once your flap is raised, these choke vessels actually have a blood supply coming from the internal perforators from the internal mammary artery, which communicates to the thoracoacromial vessels through these choke vessels, which again, as you can see in this picture, gives the perpendicular perforators coming onto the skin paddle. So understanding this is very important, because you can place your skin paddle up to closer to the midline medially, and inferiorly you cannot go beyond the the rectus sheath, maximum up to 1 centimeter, because beyond which it becomes random pattern. You do not have much of vascular crosstalk between the two angiosomes there. But medially you can go 2 centimeters beyond the muzzle, because you have certain amount of contribution from the lateral thoracoacromial vessel. So you can, this zone marked here is an area where you can safely harvest the skin paddle, being sure of its blood supply. So it's very important to understand the blood supply for the pectoralis major flap. So again, the same thing is being depicted in this particular diagram as well. So there are various defects, in the head and neck after the initial resections, wherein a pectoralis major myocutaneous flap can be harvested. So it actually, the list can go on and on, but we are all aware of it. Starting from the oral cavity defects, the laryngeal defects, the hyperpharyngeal defects, any skin that is resected as part of a radical neck dissection, or even lateral temporal bone resection for a external auditory canal tumor or parotid. So you can just go on and on for the kind of indications that are there. But it's important to understand a few contraindications. In a morbidly obese patients, the skin paddle may not survive. It's a rare syndrome, the Poland syndrome, where there's congenital absence of the pectoralis muscle, but I've never seen it over the years. But it's an indication that's been a contraindication that's been constantly said. The other thing is, which we need to be aware of, is poliomyelitis of the upper limb. So I was caught unaware in one situation, so that's why I put it as a contraindication. So when there is poliomyelitis, there's disuse atrophy of the pectoralis muscle, and it is not the muscle that you would want to harvest and place in a defect. That you would probably use it for a lateral defect after a bite composite. It will definitely not be enough time. And any previous trauma or surgery to the chest wall. So these are some of the contraindications. So with this, I'll come to the operative technique, and there are standard techniques that have been described by Stephen Aryan, but then there are minor variations that might be there. Every center, every surgeon, even within a center, every surgeon might do it a bit differently here and there. A few little tricks here and there to raise the PMMC much more effectively. So I'll just give a pictorial representation of the technique, and I'll just talk along as we proceed. So this is like a hemimandibulectomy defect, and and so for which we chose a pectoral PMMC. The patient did not want a free fibula, though we had offered it. So he wanted a PMMC because he was worried about harvesting a bone from his leg. So that's why we went ahead with a PMMC for this patient. But then this is one of the rarer situations, but most of the time we do PMMC these flaps because of various logistic issues. So the first thing that we need to understand here is that you need to measure the mucosal defect, not in a straight line, just to measure along the mucosal fold that is there after the resection, because that will give you a better understanding of what is the amount of skin flap that you would have to mark and raise. So once you have measured the extent of the defect, so that needs to be marked on the chest. So I think people need to mute themselves, so the host can mute. Right. Thank you. So, once that is done, before marking the skin paddle, what we need to know is this the suprasternal knot superiorly and the xiphoid inferiorly, and you have the midline there. That's the medial limit, and then you mark the 3 intercostal space, identifying the area where the perforators from the internal mammary would be coming into the skin paddle, and also you would try to mark a line at least 2 inches from the midline. So why we do that? This is that as you're raising the skin flap superiorly, you would not want to venture onto this medial zone. That is because you would want to preserve these perforators just in case you have you need to have a rescue flap at a later point for whatever reason that might be. So this technique is known as a defensive harvest of a PMMC. So you're trying to protect the area of the deltopectoral, its blood supply, and then you mark that area, and then you try to raise the flap superiorly. Now here the length, the horizontal dimension was about 9 centimeters. So and the patient's chest was small, so we didn't have a choice but to include the nipple areolar complex here. But then there are various techniques that have been described. You can take a vertical paddle, skin paddle, or a slightly oblique, or take the nipple, excise the nipple, and then you graft it back into the chest. But then these are all good to know. But then it's always better if you do that once you have gone past your learning curve to raise your pectoralis major myocutaneous flap. I just mentioned it for the sake of completion. Right. So once you've marked the skin flap, you mark it in an area so that the reach, you need to, okay, before I go to that, I think I have to tell you how you, where is the area of the possible pedicle here. So we have marked the midline here, and then you have one line coming from the, acromion down to the xiphoid. And then you have a perpendicular line coming down, bisecting the this line from the acromion to the xiphoid. So that is the area where you will have the pedicle running down. So, and you will have to measure the reach of your flap along this area where the pedicle is supposed to run down. So that will help you understand the reach of the flap as what is measured here. So you try to look, go for the medialmost part of the defect in the neck, keep it loose, not very taut, and then come down along the curvature of the path along which the thoracoacromial artery comes down into the muscle. So once that is done, you take a lateral extension and you go deeper down till the muscle is exposed, and then you excise the skin paddle inferiorly. You do not want to take the inferior aspect of your pectoralis major too much lower down. It should be preferably lying on the muscle. If it has to go beyond the muscle, it should not go more than 1 centimeter, beyond which it becomes random pattern. So roughly, if you take 2 finger breadths from the xiphoid as marked here, that will be more or less the area wherein your muscle attachment to the rectus sheath will take place. So you will have at that area, the muzzle, or slightly, it will be within that 1 centimeter zone. So that should be your inferior limit. In case, if you by mistake marked it a bit lower down, so you can identify it at this point. So that's why it's important to take this inferior cut first, so that based on how lower down you've gone, you can modify the upper cut subsequently. But as you learn raising this flap over the years, you would understand exactly as to how you need to place your flap. So once that is done, once you take these incisions, before I commit any of this incision lower down, I prefer to take these stay sutures. Of course, you can argue for it, against it. There is no randomized evidence to it. This is what we are being taught, and it makes sense too. So you want to, and you understand the way the stroke presence and the perpendicular come perpendicularly up. It makes sense to, anchor the skin paddle to the muzzle lower down. When we are taking this stitch, you need to be careful in that it should not be too tight. You should not make the skin touch the muzzle. That's not the idea. It's just to anchor the skin paddle to the muzzle. It should be just gently taken. It doesn't have to be tight. So it's very important we understand that. And even while taking these sutures, it should be taken very gently, keeping the skin paddle pressed downwards, and avoid shearing while taking these flaps, these stitches, because the very purpose of taking this stitch then will be defeated. And as you take, you cut open, as you excise this skin here, it's always better to bevel out rather than bevel, perpendicularly down or inwards. So that's a better technique to follow. So once you have taken these stitches, then you extend the incision lower down. So I prefer to here, then lower down, you can see as to how the pectoralis major muscle, attaches to the ribs, and then you open up this area to expose the rectus sheath. As you can see here,
Shiva,
just a minute.
Shiva, can you just tell us why you are taking incision like from the axilla till the nipple and then inferiorly? What is the purpose of not taking the superior incision?
So, just a moment. So as I just explained in the, so why I take this incision inferiorly here is, like I already told, if by chance I place this inferior skin paddle, far too lower down, then the chances of this lower part being random is higher. So to counter that, I will have a fair sense of how much of my flap is probably not going to, make it at the end of it. So I would have a sense of it to begin with, and then if it is lower down, I can modify this upper extent of the flap and raise this a bit, mark this a bit higher, compensate that 1 centimeter superiorly for what has happened inferiorly. So that is why I prefer to do this.
Yeah,
Is that all right, ma'am?
Expiratory incision is good because you can see the muscle capture on the skin paddle. So if you can see, because the anterior axillary fold is formed by the pectoralis, and that's how I initially mark the skin paddle itself. I palpate for the muscle. It's usually 1 finger width below the nipple. That's where the muscle ends. So like Shiva said, do the expiratory incision, see how much muscle capture is there, and then readjust the dimensions of your flap. I think that's the way to go.
Yeah.
All of us agree on that point.
Right. Okay. So once that is done, I can see the muzzle here, the rectus sheath. I just prefer to take some amount of rectus sheath here. You can see the rectus muzzle exposed here. And then, of course, I tend to take the stay sutures. I'm, a big, I'm not sure if I should say I'm a fan of it. I'm obsessive compulsive about it. I think that's the way I will put it. So if any resident is harvesting a PMMC with me, I make sure that resident does it. So if he doesn't do it, he doesn't get the next PMMC, at least if I'm, making him or her do it. So that's how obsessive compulsive I am about that. I might be right or wrong, but I've learned over the years, and when I've fairly standardized my technique. You can do it the way you want, as long as you don't handle this skin paddle gently. It's fair enough. So once I've delineated, taken islanded the skin paddle that you're going to take. Now the next thing that you need to do is raise the flap superiorly. as you're raising the flap superiorly, this is the perforator that I was talking about. You would encounter that if you go far too medially. If you see that, it's better to stay lateral to it, keeping that pedicle, intact for, the defensive technique of raising a pectoralis major flap. And you would raise this, skin flap, keeping some of the fascia on the muscle intact, and you raise all the way superiorly to reach your clavicle here. So here you would reach.
Well, there's one thing that I wouldn't do. I wouldn't island the skin paddle completely, because you're going to cause it to shear more when you're trying to raise the upper skin paddle. So I would always leave the sternal attachment of the skin intact till I lift up the muscle completely. That's the basic in any flap, in ALT, radial forearm, whatever you're doing. You keep one end attached to the site where you're harvesting. So even if you screw up the flap, you can put the skin back and the skin will still perfuse.
Yeah.
So only towards raising the muscle from the chest wall, that's when I'll island the skin completely. Otherwise, I wait till the upper skin paddle, lateral muscle, everything is elevated.
Right. So maybe that's one technique that you do, but then this is how I've been practicing my PMMC over the years. And of course, that's what I said. There is variation to how you do it. So so to counter what you said is that I take those stay sutures to prevent that shearing. So just by not taking the medial incision doesn't guarantee you the shearing is not happening, because if your assistant does raise your superior as you're raising the superior flap, if they don't assist you well, the shearing can anyways happen, even if you just by leaving behind not incising this medial end may not help you that much. But if it works for you, well, please, I wouldn't ask anyone to not do that. But this works well for me. So I would, at least this is how I do it, and I make my residents. So the point here is, what I would try to tell here is the no touch technique. I was trying to keep it in, tell it subsequently, but then what I tell the residents to do is, once you take the stay sutures, to stay away from this skin paddle. You have to handle this skin paddle at any point. So the more you handle the skin paddle, I think somebody has to mute themselves. Yeah. So the point here is, once you take the stay sutures of the skin paddle, I would not touch the skin paddle. So it's what I would call this as the no touch technique. So you're not supposed to touch the skin paddle, and you're just going to work around the skin paddle and not on it. So that way you would prevent the shearing of the skin paddle. So once you superiorly you raise, go till the clavicle. Laterally, you would expose the deltopectoral groove where you will see the cephalic vein, and so that is your extent of the superior, flap. And then after you're done that, you make the tunnel. So you make the tunnel enough for all your 4 fingers to go in and expand your fingers. So you should have that much of space. So because anything lesser will probably constrict the muscle as you take it, as you tunnel it into the neck. So you should have enough of skin paddle, enough of tunneling that needs to be done. And laterally, when you try to expand your tunnel laterally, you might encounter your external jugular vein there. So you need to be careful about that. Otherwise, you'll have some amount of brisk bleeding, and you might have to handle that before you proceed further. So once you're done with this, then you go between the pectoralis minor and major here, and then try to raise the pectoralis major myocutaneous flap from the chest wall. So here I'm just using the Babcocks here to gently lift the muzzle superiorly to identify the plane between the pectoralis minor here and the pectoralis major, and you can see the attachment of the pectoralis major onto the ribs. So, and you can see the serratus anterior muscle a bit more, inferiorly there. So, and then you need to raise this pectoralis major myocutaneous flap off the chest wall. And when you're using the Babcock, you should make sure that your assistant is not, trying to put too much of force on the muscle. So tissue handling is of utmost importance at every point, every point as you're raising the pectoralis major myocutaneous flap. Tissue handling is of utmost importance, because that's what will help your flap survive. Just at one point, not doing some step will not save your flap. It has to be each and every step while raising the PMMC flap makes a difference in your success of your flap. So as you're raising the pectoralis major of the chest wall. The other thing I say is always use cautery, tangential to the chest wall, not to use it perpendicularly, because if you miss the plane, you would open up the intercostal muscle and go and open and expose the pleura. You wouldn't want to do that. And so you're not supposed to, again, here, if you look at my forceps, it's just, my forceps is closed and it's just pushing the muzzle up, and gently my assistants are just holding the back cost. They're not putting more pressure than that. And you just need to, slowly, cut these insertions, release these insertions of the pectoralis major muscles from the, ribs, and then slowly raise the flap superiorly. As you raise the flap, as you go between the, pectoralis major and minor muscle, what we would generally use is use a well-soaked gauze and just to use do a gentle blunt dissection, if that helps. So once you have done that, then you can identify the pedicle, and then you will identify the pectoral nerves. So you'll get the medial and the lateral pectoral nerve. The medial and lateral pectoral nerve is more like a misnomer. It's not because it's actually the medial is lateral and the lateral is medial. The name comes from its origin from the brachial plexus, which part of the brachial plexus it originates. So the name comes from that. So you need to release the medial and lateral pectoral nerves, especially the lateral pectoral nerve. If you don't release it, it will sort of compress onto the pedicle. And once you denervate the muscle, of course, over the long run, it would undergo atrophy as well. So the other thing that we need to keep in mind is, as you're raising it, you will find this, there's a groove between the clavicular head and the pectoral head of the muscle. Here, this groove here. Sometimes it might so happen that if you're not well, the initial phase, you might not be aware of it, and you might tend to, go between these two heads and maybe, encounter the pedicle and possibly damage it as well. So that is in the initial phases, but later on, you can also use this cleavage to harvest the islanded pectoralis major muscle. So it's here that you need to go into this plane and then, release this from the pedicle and island the entire muscle and the paddle and the muscle here, and then you can tunnel it, or either you can cut this clavicular part and suture it back. So once you identify the pedicle, you just mark it here just to make sure, guide you in dividing this muscle here. So one of your fingers are below the muzzle. Just you need to palpate the pedicle and then stay lateral to it so that your pedicle is well protected, and then you cut the muzzle all along here. So the other technique which I've seen our plastic surgery colleagues do is to identify the insertion of this muzzle all the way up to the humerus there, and then just put a musky or a mosquito or artery forceps, and then just divide closer to the tendon. So that might be a bit easy. I think whatever anybody is comfortable with can be done. So I prefer to cut the lateral part of the muzzle first, because that is the more bulkier part of it, and it's the difficult part, because if you cut the medial edge, you wouldn't have that support, which is, which at present it is there as it's arising from the sternum. So I would like to cut the muzzle laterally and then take the medial cuts subsequently. So as you can see here, you just cut the muzzle all along towards the deltopectoral groove here, keeping your finger beneath lateral to the pedicle so that the pedicle is protected. So as you go lower down, as you cut the muzzle, you will have this fascia coming up where the pedicle is, deeper to this fascia. So it's always better to stay above this fascia, not to divide this fascia at this point. You cut the muzzle all along till the, the deltopectoral groove, exposing this fascia without going below, cutting this fascia, because your pedicle is right beneath it. And that I would suggest we cut it once we have delineated all across till the groove, and then with direct visualization of the pedicle, it will be much safer to cut this fascia all along till the deltopectoral groove. That way, it will help us protect the pedicle and release the muzzle all along well, as shown, as depicted in these two photographs. So once the lateral, release is done all the way till the deltopectoral groove, Also, you will come across the deltoid branch of the thoracoacromial vessel, which is also essential to identify and ligate for a better reach of the flap. And also, I've been taught by Anuja madam as well, saying that it also avoids the steel phenomena, so that you a good amount of blood supply to the paddle. So there's no amount of blood anywhere else other than the skin paddle. So probably that helps in the survival of the flap. I mean, these are not hard facts, but it's a logical conclusion that you can derive. So once that is done, you see some perforators here as well. That is coming from the intercostal space. You just need to cauterize it well, cut the muscle all along the same way, exposing the fascia and then cutting the fascia directly with the pedicle in under vision. So this is the deltoid branch of the thoracoacromial artery that I was just talking about, which needs to be properly ligated. Otherwise, this can also be a source of bleed later on. So once that is done, you need to, as you're working on the, as you're raising the flap a bit from the pectoralis minor muscle, I would suggest you use a bipolar, because it has happened that when we're using monopolar there, if the patient is light, if there's not enough muscle relaxant given, the muscle twitches and you might accidentally your cautery might go and hit your pedicle. You don't want anything happening to your pedicle there. So that's why I always suggest to use a bipolar, and that way it is much better. And once you've raised it from the clavicle, you can just take some amount of muscle off the clavicle again to improve the reach. And I would prefer to just push the muscle into the neck through the tunnel. If your tunnel is good enough, you just push it, it just comes into the neck. I wouldn't want to pull it with a Babcock or any other instrument just to avoid any shearing. That's the technique I follow. I mean, anybody can follow any other technique, but that's what I'm most comfortable with. So the other thing that once the flap is into the neck, it's then can be sutured on. So the other thing is the lateral dominant pedicle. So it's a very rare thing I've come across in a very few patients, but it's very important to be aware of it. You see that sometimes, the lateral pedicle will be more dominant than the medial pedicle. If that is the case, you just need to follow the lateral pedicle and just divide the pec minor muscle. As seen here in this, you can see this is the pectoralis minor. The pedicle is coming from here. You don't see the lateral, the medial, the pectoral branch of the thoracic. So you must suspect that probably this is the, the main pedicle. So the teaching is first you see the lateral pedicle, you ligate. Never do that. You don't ligate the lateral pedicle till you see the medial pedicle. That is the main pedicle. So if there is anything, you can see this pedicle is almost non-existent, and you see here, this is so robust. So you just need to go across this pec minor, release it so that you get the reach and you can raise the flap with the intact lateral thoracoacromial vessel. So it's a very important thing to identify. So that's the other thing that I tell the residents is not to take the lateral thoracoacromial artery till you see the main pedicle of the flap. And then based on the caliber of the vessel, you can come to an understanding as to if the lateral pedicle is actually contributing to the flap or not. So this is the technique group. And of course, you can use this PMMC for any defect. I've just put these pictures for the sake of completion. You can even do it for a total glossectomy with a posterior segmental. You can take a nice big PMMC and just put that in. It's a bipaddle PMMC that you would want to do for a lateral mandibular defect. And you can see here up to 2 centimeters or just more than that is outside the muzzle. But you can be rest assured that if you raise it well, it would survive. And you use it for patch pharyngoplasty as well. Here the marking would be, I just look for literature, but then what we are taught is 12, 9, and 9. I think Mayur can explain this further. So 12 is for around the base of tongue, 9 is in the midline and the middle portion of it, and another 9 centimeters is lower down. That's for a tube. You measure the amount of pharyngeal mucosa that is left behind, and you can detect it from the 12, 9, and 9, and create a paddle, and then design a paddle as per your defect of your following a partial pharyngectomy, total laryngectomy. You can use the spiral PMMC, that is, you harvest like PMMC and you just rotate it around, rotate it about 180 degrees. It's a very, it's tricky one. You need to be sure, flap should be, raised very freely, and make sure that the pedicle is not taut. It's not, it's not getting twisted. Otherwise the flap can get decongested if that's not taken care of. It can be used for a defect after a radical paratectomy, after a subtotal temporal bone resection as well. And you can use this even for an intact mandible defect, wherein the muzzle goes on the inner aspect and you can have the skin for the outer aspect. So you can have it for various defects. It's for after a radical neck dissection where you need to do a reverse marginal mandiblectomy. You can do it for that as well. And other variant, the pectoralis major myofascial flap, we do it after some sort of an extended hemiglossectomy as well. But remember, this just acts like a diaphragm which just plugs the defect. It's not going to help in the tongue mobility in any ways. So at the end of it, the points to remember is be sure of the measurements and the reach of the flap. You measure the defect well, and you can just go maybe 0.5 to 1 centimeter more, but not less. Because as you cut the skin paddle, as everybody is aware, the paddle just shrivels a bit. So it's better to take more rather than be, found short of your, amount of skin paddle that you want, and you'll be, in the bargain doing something, and that might, contribute to your flap loss. And the reach, it should not be too tight. Be sure of the reach. If it is too tight, you're doing some, bargaining again to make the flap sit where it has to be, then that again will, be counterproductive. Do not handle the skin paddle. As I said, I adopt a no touch technique. Once you island the skin flap, you can choose not to island the medial part of it. That's your technique. I do the islanding and I see to that nobody touches the skin paddle. And so that's the kind of obsessive compulsion you need to have while raising any flap for that matter, but definitely for a PMMC. Handle the muzzle gently. As the muzzle is raised from the chest wall, the cautery must be used tangentially. And do not divide the lateral pedicle before visualizing the medial pedicle. Divide the deltoid branch of the thoracoacromial vessels for better reach and to avoid the steel phenomena. Use bipolar cautery, preferably near the pedicle after the flap is raised. Keep the tunnel broad enough. While suturing the skin flap in the neck, exercise caution. That is when you're closing. Especially when you take a vertical drop when you're closing. It has happened that while taking the vertical drop, everybody's done the first assistant or the junior most person is suturing the neck flap. So sometimes you're not cognizant of what you're doing, you'll hit the pedicle there in your neck. So be careful about that. The flap is still not over. So to conclude, PMMC is a very robust flap. It still remains one of the most widely used flaps for reconstructing head and neck. And I would call it a workhorse of head and neck reconstruction. Of course, you have free flaps, but 50% of the time you do PMMCs. It's a robust flap with constant vascular anatomy, technically easier flap to learn and do, and pay attention to details while raising the flap to minimize complications. And this flap is an absolute example for this phrase, respect, you give it to get it. If you respect the tissues, you earn its respect, and it respects you by giving less complications. So I would like to end with that. Thank you.
Thank you, sir. Excellent presentation. I agree completely with whatever you have said, sir. Another point, another procedure that I do while raising the flap is I release the clavicular head so that I get around a centimeter or 2 of extra muscle, extra length. So the tension on the flap is not there. Other than that, exactly same. Nothing is different from what you are doing.
Shiva, can I just comment something? So 2-3 points I just thought I do little differently how Deepak has said. Like after you take the incision from the axilla, you go down and check the inferior extent of the PMMC. And after that, once I have confirmed that, what I do is check the dominance of the vessel. So that beforehand only you know that whether the patient has got a lateral pedicle which is dominant or the medial one. And then you can go ahead and do the rest of the thing. That is one thing I do differently. And you said about the doing and needing a patient a ICD after doing a PMMC raising. So once I had encountered that, and I have seen that done by very experienced person. So, and it can happen to a person when you are raising a very ambitious bipedal flap. So you should try to avoid it. And you should learn that you raise a plane between the pec minor and major, and then you go ahead. That will avoid doing this kind of a problem. The third thing I want to say about the costochondritis, never burn the cartilage, the ribs, basically. If you burn the ribs, this patient will come with the chondritis and they will have a constant chest pain. So try to avoid that. And whenever you raise a spiral PMMC, you have to encounter extra 1 inch for that one rotation is to be calculated for the reach. There are lots of points are there, but I think these are the bare minimum I would like to contribute. Thank you so much. It was a great presentation.
Thank you. Shiva, it was very good presentation, Shiva. I totally agree with all the steps. One thing that the resident should know is that if you're raising a very large pectoralis major, the choke vessels are in the fourth intercostal space. So you try to include the skin of the fourth intercostal space if it is possible. That is the first one if you're raising a very big pec major. Second, you put the most robust part of the pec major intraorally. So you always try to take the more proximal part of the pec major inside the oral cavity, so that even if the tip fails outside, you can skin graft, you can put a DP, you can do whatever you want. Third, the resident should know that the vessels come vertically through the clavipectoral fascia. So if you start digging under the muscle closer to the clavicle, you'll hit the pedicle. It doesn't run along the muscle just like that. It runs actually, it pierces the clavipectoral fascia, goes vertically, and then enters the muscle. So residents have to be careful of that. And the last thing is, if you do too tight a chest closure, patient cannot breathe. Okay, patients will have pulmonary complications if you close the chest too tightly. So if you can recruit tissue from the anterior axillary fold, if it's a pendulous chest or whatever, then that's fine. But otherwise, skin grafted and like Anuja said, you should not make the ribs devoid of perichondrium. Otherwise, the graft won't take. So that's an important thing. And I always inverse plan. I take a piece of paper, glove paper, mark out the defect, cut the defect out on the piece of paper, cut a pedicle out on the piece of paper, and then just flip it over the chest and mark the pec major that is required. So inverse planning also is very good if you want to, for complicated defects, defects which are palate to the floor of mouth. You need a donut shape, a kidney shaped flap. So you can do inverse planning and do that. So these are some of the things that can be done. And like you mentioned, the nerves are different. The medial nerve is lateral nerve is medial. So the medial nerve actually pierces the pectoralis minor and comes to the pec major. That has to be divided. And the lateral branch runs along with the pedicle. So you'll have to dissect the pedicle a little bit to cut that nerve. If you don't cut the nerve, the muscle doesn't atrophy. And each time the patient abducts or internally rotates the arm, the muscle twitch will be there. So these are some of the points that the resident should remember. Thanks.
Yeah.
Thank you. Good evening, Dr. Shiva. Dr. Mayur here.
Hi, Mayur. Yeah.
Yeah, very nice presentation. Just a few points I would like to make. One is that you commented that the cutting of the lateral part of the muscle close to the humerus. Actually, I don't think it is a very good idea, because it would create a lot of bulk in the neck. In that case, it would be a lot of bulk of the muscle. Usually it has to be, and also the cephalic vein can be injured in that case. Just medial to the cephalic vein is where you would divide the lateral part of the muscle. And
I said some of them do it, but I don't do it. I totally agree with you that we want to keep the bulk of the muscle less. So I would.
Yeah, so it should be just about 2 centimeters from the pedicle. At the max, you should go up to the cephalic vein.
Agreed.
And
very good point, Mayur. Actually, it's a very nice point.
Yeah, and like other people said, we just take the lateral incision and identify the lower border of the muscle. Only then we take the lower incision, so that we can base our pedal properly. And about the dominance of the lateral pedicle, you just like you mentioned, sometimes if you are not very sure whether the lateral pedicle is dominant or the medial pedicle, we can just put a clamp on the lateral pedicle sometimes and see how the flap bleed is. Wait for 20-25 minutes. before cutting the lateral pedicle. And if there is some doubt, then you should always keep the lateral pedicle intact and dissect it when you And for planning of the pharyngeal defect, just like you said, we also do the same thing. Upper is the 12 centimeter is the circumference, then 9, and in the lower part it is about 8 or 7 centimeter. We divide the remaining mucosa from this, and then we plan the PMMC in the inverted bell shaped. And at the upper end, there should be a wedge of the muscle which will be fed in the esophagus, where we give a slit to avoid the stricture formation.
Actually, there are so many minute variations at various points as we raise this pectoralis major flap that each and every one of us might do it a bit differently. Yeah. So that is why the pectoralis major flap, even because of these minor variations between surgeons, the flap is still so robust, and it is it takes care of all these variations that each individual has. So that's the beauty of this flap.
Excellent presentation, Shiva sir. I just wanted to make a comment regarding female PMMC. In the hello.
Yeah. Go ahead.
Yeah. In the comment section, there is a question whether is there any technical difference when doing a. I mean, I do not advocate PMMCs in women, but yes, is there any technical difference in raising the flap?
So no, the same technique, and you have to be extremely careful about the skin paddle. I take the stay sutures again the same way as I told you, and I'm more obsessive compulsive if I'm raising a female PMCs. I mean, we don't raise a female PMMC in a female patient because we don't want to distort the breast of the female patient. Yes, so we've actually done away with. I've done female PMCs in the past, but I've stopped doing it over the years with with more and more free flaps being utilized for our patients. If it's a female patient, we tend to offer them a free flap rather than do a PMMC. But then if there's a flap failure or for whatever reason, you have to do a PMMC in a female patient. It's not a contraindications. You follow the same step. You take the stay sutures and do not touch the skin paddle, for heaven's sake.
One or two things we have to be careful when doing a PMMC in female is that you have to base your paddle a bit medially also. Medially, yes. You have to avoid the nipple area most of the times. So it has to be either some vertical paddle or a small paddle based.
And a crescentic paddle for bipaddle.
Or a crescentic pattern to avoid, because in the nipple area region, the fat content would be the maximum. So we have to avoid that. So paddle would be a bit medial and a bit inferior in a female.
Correct. So we would avoid the nipple areolar complex when we are doing PMMC in a female patient. I forgot to mention that. I totally agree with that. Yeah.
So just to add on my opinion, when we started doing this PMMCs, that time free flaps were not done so much in Tata. So we used to do very frequently female PMMCs, and the bipedaling the female PMMC is used to be no, even when we didn't have the option of free flap. So in that time, we used to do a double flap, that is DP along with the PMMC. Because folding a flap, which is already a tricky flap, in a female patient should not be done. So preferably a single paddle flap and doing a DP for the outer defect. That's what we used to plan, apart from what you have told about the female PMMC.
So the question as to role of PMMF, I see one question, but usually, I mean, PMMF, we do it, but then usually in women, the bulk of the PMMF would be very minimal, and you wouldn't probably doing it for a buccal mucosa defect. You'll probably be doing it for a tongue defect, wherein the business area, that is the distal part of the muzzle, is already, the bulk is not there. It may not help you. You would probably do it only if you don't have, in a salvage situation rather than upfront. We have done it in the past upfront, but then as of today, I would do it in a salvage situation. I think others can comment.
So you can do a PMMF in a female patient, and you can take a submammillary incision. In a male patient, I will take like one oblique incision or something like that. But in female patients, strictly I'll take a submammillary incision so that at least it is hidden.
Yeah, agree. So, so if there are no further questions or comments,
I think the organizing team can conclude the today's session. I think.
Yeah. Thanks everybody.
Yes, sir.
Thank you, sir.
Thank you.
Thank you, sir, for this excellent step-by-step demonstration. And thank you, panel, for your crucial inputs regarding this flap. So with this, we come to an end for this day one. Tomorrow, we shall commence the session sharp at 9:30 a.m. Thank you all for your cooperation. Good night.